Sound check 1 2 3. Sound check 1 2 3.
Good morning. Welcome to the Public Health Committee meeting of September the 30th, 2024. I would like to call this meeting to order. Please note the quorum is present. Joining me in council chambers, Councillor Ted McMeekin, Councillor Tammy Wang, Councillor Mark Taddison, Councillor Jeff Beattie, Councillor Cameron Critch, Councillor Brad Clark. On screen, Councillor Matt Francis, Councillor Narinder Nan, Councillor Craig Kassar, Councillor Mike Spadafora, Councillor Danko, Councillor Esther Pauls. Thank you. Before we turn our attention to the agenda, just a few words about today. National Day of Truth and Reconciliation is a day for us to learn more about the history and the legacy of the residential school system. It's a day to honor the resilience, the dignity, and strength of survivors and intergenerational survivors, to acknowledge and accept their experiences at residential school and remember the children who never came home. It's a day to learn about Canada's colonial history and how it has and continues to impact Indigenous communities. As Canada's Governor-General Mary Simon stated, it's a day to remember that only darkness comes when policies mix with prejudice. Let's commit ourselves to light and the justice that comes with light, and that justice depends upon truth. The orange shirt is a symbol of the stripping away of culture, freedom, and self-esteem experienced by Indigenous children over generations. We wear orange to honor the thousands of survivors of residential schools. Today and every day, every child matters. May each of us continue our journey of learning, deep reflection, and dialogue on the meaning of this day. Elsie Gauthier, are there any changes to today's agenda?
Chair Wilson, there are no changes to the agenda.
Okay, it is moved by Councillor Wang and seconded by Councillor McMeekin to approve today's agenda. Thumbs up for me.
Councillor Pauls, I'm just waiting on your vote. Thank you.
That carries 14-0. Thank you. Any declarations of interest? Seeing none. May I have a mover and a seconder to put the minutes of August 14th on the floor, moved by Councillor Wang, seconded by Councillor Pauls. Speaking of Councillor Pauls, I understand you have an amendment to the minutes. Could you introduce your amendment and your seconder, please? And you're muted.
Councillor Pauls, you're muted.
Councillor, can you have someone else read it for me?
Yes, I certainly can. Councillor Wang, would you like to move the amendments? And Elsie Gauthier, just describe the amendment, please.
When the minutes were prepared, the changes to the outstanding business list were omitted, so this amendment would put them back into the minutes.
Okay.
Thank you.
Thank you very much. So the minutes as amended, Councillor Wang, Councillor Pauls. Thumbs up for me, please. Thumbs up from Councillor McMeekin, and thumbs up from Councillor Francis and Councillor Pauls. The vote is up. Thank you, Councillor. Thank you. That carries 14-0. It's moved by Councillor Clark and seconded by Councillor Cretch to put the communications item on the floor, which is 5.1, Greater
Sorry,
Hamilton.
Madam Chair, we would just need to vote on the minutes as amended. The previous vote was just the amendment.
Thank you. The minutes as amended, please vote. Councillor Jackson, thumbs up. Councillor Pauls, thumbs up. Councillor M. Wilson, thumbs up. Carries 14-0. Councillor Clark, Councillor Cretch are moving and seconding the communication, 5.1, which is Greater Hamilton Health Network respecting the physician recruitment program, 2023 and 2024. It's an annual report. Any discussion on this item? Councillor Wang.
Perhaps I could ask for a quick little overview on this. I have been listening at AMO, Chair, and AMO has, many of the municipalities at AMO are also speaking about physician recruitment in many of the smaller rural townships. In this communication, it is very thorough in terms of the amount of work that we're doing. Just wondered if I could get just a quick little overview on this.
Thank you. Who would like to speak to this matter? Oh, Director.
Thank you for the question through the chair to the councillor. So you'll recall that we've been bringing forward an annual report around physician recruitment to Public Health Committee for some time. Historically, this annual report was under the City of Hamilton's Physician Recruitment and Retention Steering Committee. And you'll recall that in this 2023-2024 is the first year that the Greater Hamilton Health Network is really taken over the roles and responsibility of physician recruitment program. So we have Melissa McCallum here with us today, who her staff have written and prepared this report. So I'm just going to invite her down to provide a bit of an overview.
Excellent. Thank you.
Thanks, Jen, through the chair. So as Jen described, the physician recruitment program has been a legacy program in the community funded by a number of partners who saw that physician recruitment was an all-of-city approach. So when the Ontario Health teams developed, and I'm actually going to go through this a little bit in the presentation that Brendan and I will do, we actually have a formal primary care network. It made a lot more sense to attach any human resources looking at primary care to be synergistic with all that we're doing around primary care activities. And primary care recruitment is obviously a very large focus. We do not have enough family providers in our community, and we are not graduating enough. So this program has been really aligned to not only securing and getting physicians from across the world actually to land here in Hamilton. It's also about connecting them to a broader sector now that we've done a really great job of unifying it. The interesting thing is that in the report, you'll notice the GHHN spans a catchment area of more than just Hamilton. It does include Haldimand County. In February, Haldimand County actually gave a very large investment to secure rural recruitment activities as part of the GIN. They invested over 3 years to allow us to hire a recruitment coordinator that will focus on those rural aspects of our catchment area, the Haldimand area specifically. So very much seeing that municipalities are understanding that this is an important, all-partner approach. And those two coordinators now work together. They work together provincially and internationally to recruit physicians to either come back to Canada or to entice them to come and practice here in Hamilton and Haldimand.
Councillor Wang.
Thank you for that. I do see that we are, just as Melissa said, we have been very successful with this. Just wanted to understand a little bit more about what are the potential whole of community approach, because in this report, you do see a lot of different organizations that are involved, but are there any best practices that we can potentially share with other municipalities as they have identified this as a massive gap within their communities?
Who would like to take that?
Through the chair, I think that we've We are the only Ontario health team to align physician recruitment into our program, which I think is an incredible first step at helping to unify a primary care sector that hasn't always felt together. There's multiple practice models in our province, and really whose responsibility is it to unify that sector? The Ontario Health Team has done a lot of that work. With that work comes a connection to physician recruitment and to all the expertise and resources we have around primary care. So I do think that we have best practices to show. We've just actually released a primary care handbook. Every physician who lands in Hamilton is, part of something much larger. There's some offerings that you have. There's a great team that's behind you. And then in terms of, municipality contribution, we do lead the way on that. And seeing such a rural community like Haldimand really weigh in to helping solve this problem has been a tremendous opportunity that we've wanted to share. Our physician recruiters are also part of larger alliances, both in the West region and as a province. So they are able to tap into other discussions provincially around where physician recruitment best practices are surfaced.
My last question then for you, Chair, is you touched upon attracting international physicians to Hamilton and to the GIN network. Could you share a little bit about how you're doing that and how are we becoming a much more welcoming community to those international physicians that are choosing Hamilton to be their home?
Through the chair, yes, international recruitment is a very large part of this. In fact, many medical students actually travel abroad from Canada and are practicing and studying elsewhere. A part of, international recruitment is showing that these physicians can come home to Hamilton and have a really robust practice along with a team. I will say providing a team-based care environment is one thing that we are hearing is the most enticing reason why people want to land in practices. Gone are the days of solo physicians opening up a practice on their own. We are seeing younger graduates wanting to be as part of a team along with other multidisciplinary professionals. So we are already underway with a strategy to expand that team-based care. The one challenge is around immigration and settling in physicians that way. We do need assistance from the province and Ontario Health around some of that work. So that's active advocacy underway. But I'd hope that, there's other offerings. You land in Hamilton, the primary care network offers, linguistic services for your clients. We're building up a sector that when people land here, they feel part of a team and they are going to have, increased focus on populations that they're going to serve based on geography. And we've done a lot of work at understanding what are the needs of those geographies and how do we help physicians settle into more of an environment that they have work-life balance, but also a connection to a greater sector.
Thank you. I had the pleasure of sitting on the physician recruitment network for one meeting, and then it went and it got removed out of the city of Hamilton and into the GIN network. So I'm very thankful for the leadership of Melissa and our team on this particular file, especially because primary care is so incredibly important. Thank you, Chair.
Thank you, Councillor. Thank you for those answers, Executive Director McCallum. If I could, I just have one question. It's sort of tangential to this. If I could ask Councillor Tattison to assume the chair, please.
Go ahead.
Executive Director, you've mentioned advocacy, you've mentioned immigration, you've mentioned overseas efforts at recruitment and welcoming people home. What's not specifically referenced here is the story that I'm sure all of us have experienced in when we have a family at a hospital who engages with a technician who is a former radiologist who had to flee Iraq, but can't afford the time and the cost to get accreditation here. It seems, it just makes no sense to me. It's never made any sense to me. And I'm wondering if you could speak to that, please, through the chair.
Through the chair, yes, absolutely. We hear these stories so frequently and we're not utilizing the expertise that is within our community. And that is the work of more higher up provincial bodies than the Greater Hamilton Health Network at this time. The really great thing is that because we've had physician recruitment so steadily available in this city. We do have the ears and eyes of the ministry and Ontario Health around this. And this is not a problem unique to us just in Hamilton. But the more that we can advocate and you know, at best guess, we have about 75,000 people in our city that do not have a family provider. You know, we need all hands on deck at all levels of government to understand how we can unlock the resources that are also already here, along with international recruitment.
Thank you. I take your point that the responsibility and the decision rests with higher levels of government, but each of us, we're all patients, we all have families, and I think if we all have an opportunity in whatever table we serve to raise this, is important. The second question I have is, do you have knowledge of where physicians actually live in Hamilton? And I'm asking because you referenced, for example, in Dundas, they like living there. It's quaint and green, but you reference high housing prices. And I'm just trying to, and something else is used in the description of the lower city. I'm just asking if you have any information on where people actually live and where they practice, through the chair.
Through the chair, no, I don't have information on where physicians are living. I will say from the snapshot of physicians that sit around our council tables, I would say the majority of them live in Hamilton and practice in Hamilton, but I don't know. It's taken a while to even get the addresses of primary care physician offices in the province, so I unfortunately don't have that information.
Thank you. Thank you for the opportunity. I will assume the chair. Councillor Clark.
Thank you, Chair. Thank you for the opportunity. I have a couple of questions. So on one of the pages, it shows all of the funders, if you will, and there's a huge list of them, all the hospitals. Can I ask, what's the province contributing to programs like this?
Through the chair, the province does not contribute to our local program. The province does have legacy physician services through HFO Canada. Those are more based and smaller amount of resources across the whole entire province. So it is something that across the province, you know, local communities are actually taking into their own hands to some degree to fund physician recruitment. So there's various funding models. Ontario Health does provide some linkages to job portals, et cetera, but very much across the province, cities, municipalities, and health providers, I would say are weighing in a lot into physician recruitment right now.
I won't ask you to comment on the political aspect of this, but it is disappointing that the province, who controls all of the levers in terms of how many doctors graduate, how many doctors can come in and function in the province of Ontario, and they're not at the tables for physician recruitment. Specifically, we're talking about family physicians, correct? Because it talks about physician recruitment, but not family physicians. That's what this is all about. So we're not bringing in specialists, we're simply family practice.
Through the chair, yes, this is about family practice and locum support. There are some programs within our program that see, you know, assistance to some hospital programs like the satellite health facility that's available. I will say the province is starting to make more investment into primary care, especially around team-based primary care. We saw an investment in it last year. But I'm with you. I would like to see more investment. This is a massive area of concern as patients do not have a primary care medical home. We know that we are not going to get on top of all the other issues, so I would gladly like to see the province weigh in.
Thank you. Can I ask another question, Chair? What's a locum defined as?
Through the chair, a locum comes in to take over a practice for a short period of time. Say they're covering a medical leave or a maternity leave, et cetera. So they come in, take on the the physician who's leaving's roster for that period of time until they come back.
And do we have more interest in locums rather than setting up family practices? You mentioned that some of the newer doctors are looking to kind of, okay, I'm a doctor, he's a doctor, he's a doctor, we'll all get together and we'll have a doctor's office. So is that what's drawing away from locums, or are locums still the go-to for graduates for medical school?
Through the chair, I'd have to look through the data on how many locums versus, locum provides doctors to see a taste of different types of practices before they settle in. But, anecdotally, we do know that younger physicians want to land in a team-based environment and aren't necessarily, wanting their own business type model. They want to be practicing along with other professionals. But that's something I can follow up with in terms of the locum data.
Yeah, at one point in the city of Hamilton, we had more interest in going to locums than in setting up family practices. And it would appear that when you're speaking to these physicians, the concern is setting up the family practice and paying for all that equipment and the lease and everything else without even having patients yet. And so it's a huge cost and gamble, and that's why they're looking to share or diversify the costs. Thank you again for all the work on this file.
Thank you. There are no further questions on this item. It's been duly moved and seconded. Thank you, Executive Director.
Councillor Kassar, we're just waiting on your vote.
Thumbs up. Thank you. That carries 14-0. We're on to delegations. We have a single delegation today. Dr. Ina Berdachevskaya. My apologies. It is respecting the closure of a supervised consumption site. Moved by Councillor Taddison and Councillor Wang to put the delegation request on the floor. Anyone to speak to this item? Seeing none. An electronic vote, please. Vote is up. Carries 14-0. Thank you. Before we begin our delegations today, members are reminded that questions of the delegates are for clarification purposes only and not for our debate, beg your pardon. A note to our delegate, I believe this may be your first time. You have 5 minutes to complete your delegation. You'll hear a ding at the 4-minute mark, just to advise you that you have 1 more minute to wrap up. Good morning and welcome.
Thank you so much for having me. Am I all right to begin?
Yes, please.
Yeah, okay. Madam members of the Public Health Committee, my name is Dr. Ina Berdachevskaya. I'm a staff internal medicine physician working in Hamilton. I'm also an inaugural member of the Hamilton Homelessness Mortality Data Project. I come to speak to you both as a physician, as a researcher, as a proud Hamiltonian and a resident of the Lansdale neighborhood, and perhaps most importantly, as a human, regarding the planned closure of the safer drug use spaces in the city, and specifically the consumption and treatment services at Urban Corp. So from where I'm standing, I come to work every day, and among my patients, I have individuals who use drugs, both housed and unhoused alike. I see people who have overdosed, many of them multiple times, because of the toxic and laced drug supply out on the streets. And I treat the complications of drug use, most commonly the infections that can result from unsterile techniques when using things like reusing and sharing needles. And as much as it breaks my heart over and over again, I see people dying long, long before their time because of all of this. Invariably, these are people who have been marginalized by policy decisions and by society at some point deciding that it doesn't care about them despite them being our neighbors, our friends, and our family. I imagine that most of you are likely familiar with the data that the Homelessness Mortality Project has been collecting, but I'll read you some of the highlights. So we've been doing this for about 3 years, and we've learned about a total of 116 people so far, with an average age of just 45 years old who've died over the last 3 years. Of them, we know of at least 54 that have died of an overdose, with another 9 dying of infection, and 20 dying of unknown causes, with at least some of them, I imagine, also attributed to overdose. 70 of them have died in locations outside of hospitals. But worth noting that 0 that we've heard of have died inside a supervised consumption site. The people who are already dying of overdose are very largely dying of them in locations where they're unseen until it's too late. And lethal overdoses disproportionately affect our unhoused neighbors, but they're not unique to them. You can look at these numbers alongside those that Hamilton Public Health puts out themselves. Last year, Hamilton Paramedic Services responded to 80 overdoses per month. And then in the same time, there were at least around 60 emergency visits for opioid toxicity per month. The coroner's office confirmed 148 deaths related to opioids in just 1 year. Now, to speak to supervised injection sites and how they've likely helped those numbers be lower than they otherwise would be, the research is overwhelmingly in favor. In science, we like to look at systematic reviews. They're kind of our top tier of evidence. And a systematic review of 47 studies published in 2017 established that the establishment of supervised injection sites was associated with a reduction in the number of public injections, publicly discarded syringes, and injection-related litter. There was also no increase in crime rate in the surrounding areas. Now, in Canada, we're not alone. There's currently 38 supervised consumption sites, which over the last 7 years have attended to over 55,000 overdoses. That's 55,000 lives that were potentially saved. The Urban Core CTS serviced 391 clients in the year between March of 2023 and 2024, with nearly 7,000 harm reduction service visits, and responded to 55 overdoses. Now that's, remember, 55 on top of the 148 that we know died of opioid-related toxicity. So 55 potential lives saved, and the CTS had, once again, 0 deaths at their site. I, as a physician and as a person, am so scared that if we take this service away, those are 55 lives that we're going to lose. Not to mention getting rid of a location that distributes harm reduction supplies that prevent our neighbors and my patients from getting life-threatening infections. Now, I'll be open in saying I don't have a great understanding of how things work from a regulatory perspective. I'm just a concerned citizen. You committee members do. There needs to be a way to keep these life-saving services going, despite the provincial government's new rulings. And whether or not this city can figure those out will determine how many lives are lost in the coming years. Thank you.
Thank you very much, Doctor, for your delegation. If you would stay with us for a few minutes, we have a question from the floor. Councillor McMeekin, please.
Yes, thanks, Chair, and thank you, Doctor, for bringing some enlightenment to the discussion that is so pivotally important in our community. It's interesting to listen to the statistics, 38 sites across Canada, 55,000 people provided with a very necessary service, and how that compares to death rates in unsupervised communities, I suppose, encampments as well. By the way, that's another darn good reason for the larger sanctioned communities in terms of knowing where potential medical difficulties are. In chatting with the police chief, I know that one of the concerns that his folk and those who respond to crises have with the current encampment situation in parks is they often don't know exactly where the location is, and they have trouble getting there, I'm told, quickly enough. But here's my question. I guess I have 2 questions. The first question is, Doctor, given the unquestioned, from what I heard, reality that supervised sites save lives, what rationale has been given for the recent provincial decision to dismantle the ability to set these up in the community. Do you have any insight on that?
I mean, my insight is limited to the statements that they've published, and it is, honestly, it's rationale that does not make a ton of sense to me. They've commented on proximity to childcare, but have not provided an opportunity to apply for alternative permits, is my understanding. Again, I'm not involved in actually physically setting these things up, and nor am I involved with the provincial government. To me, it seems like a very heartless decision, but I am just coming here as a concerned citizen.
Councillor?
Thanks. It worries me that I know it's a controversial issue, Chair, and I would agree with those in the community who would suggest that if we're going to move to sanctioned sites, we need to be very cautious about how and where they're located. I agree with that. But it just seems so...
Question, please.
Yes, it seems to be counterintuitive, and I wonder... I suspect to know the answer, but does the doctor believe it's counterintuitive to essentially be an advocate of unsanctioned sites versus something that has clearly been shown to be much safer in terms of human response and lack of deaths?
Doctor?
Through the chair, just a clarification for the member. When you say being an advocate of unsanctioned sites, what are you referring to?
Well, anything that isn't sanctioned, I guess, would be an unsanctioned site. You know, we hear concerns from the community about picking needles up in parks and the fear to go into parks and such.
If I may, you're asking for the doctor's opinion on the provincial policy or the provincial announcement?
Yeah, and she's begun to do that. I guess I would, the appropriate supplemental would be say, what kind of advocacy initiatives would you suggest to correct what, in my humble opinion, and I'm not a doctor, my wife's a doctor, she'd have a less than humble opinion, but what kind of advocacy efforts do we make, and how can we best address this?
That's a great question. And, but, you know, like I said in my delegation, I don't have a great understanding of how the policy numbers work. But I am aware that there's another site that's functioning. My understanding is through a different pathway, of a different legal pathway. And so I am hoping that the city can pursue other avenues to make sure that these sites stay open in a way that is in keeping with the provincial regulations. As heartbreaking and, in my opinion, nonsensical as they are.
Thanks for your engagement. Thanks for sharing your perspective with us. It's important. Thanks.
Thank you, Councillor. Up next, we have Councillor Nan, followed by Councillor Kretsch and Councillor Taddison. Councillor Nan, please.
Thank you, through you, Chair, and thank you, Doctor, for your delegation. I was wondering, given your area of expertise and understanding, I guess we're all evolving our understanding of the new provincial Heart Hub model. What do you feel is most important for the Public Health Committee of Hamilton to be aware of in terms of that shift from what was funded and what the Heart Hub models are proposing?
Yeah, thank you for the question. So my understanding of the Heart Hub models in terms of the things that they were very clear that they will not include is the use of harm reduction supplies or the distribution of harm reduction supplies. So specifically things like clean needles and cookers, and they will not include supervised injection sites. Now, those are two things that are very highly evidence-based in terms of saving lives. On where, you know, from where my expertise stems, I am seeing the infections day to day that come from people not being able to access clean needles and not having them in accessible enough locations. And the more locations that we provide throughout the city that provide them with those tools, the fewer of those infections we're going to be seeing. So I would really highly advocate for that to be something that's available. And and understanding that the province's limitations, but also understanding that a municipality holds more power than an individual citizen in terms of advocacy for changes to what the province is suggesting. And then, supervised injection sites themselves, I have already spoken to.
Thank you so much, Doctor.
Thank you. Councillor Cretch, please.
Thanks very much for your delegation today, and I'm hoping that at the end of maybe your delegation, there's time to ask staff a question or two about the sort of provincial regulatory framework, to get a better understanding of exactly what paths are available to municipalities. But my question is with respect to, and first of all, thank you for the evidence and fact-based delegation. I think it's really important that you brought these facts today and talked about this. What I heard you saying and speaking to was mortality data, and you were talking a little bit about, well, what happens when people don't have access to supervised consumption sites, and I'm reading between the lines that sometimes they will not be, or they'll be somewhere in a place where more harm can come to them. Could you unpack that a bit more in terms of what this is providing in terms of a safe place and what that means for the community?
Absolutely. So like I mentioned, in terms of, overdose deaths, we do know disproportionately affect people who are living unhoused, and we do know that a large proportion of people who are using supervised consumption sites are unhoused. And what they're providing is the opportunity to use the substances they're going to be using regardless of whether we provide them that space or not, but to use them in a space where there is trained staff around them that can recognize the signs of overdose and respond to it and save lives. So that really is the main service that they're providing. And my fear is we take away this this place that we know has reversed 55 overdoses over the last year, and then that number of 70 people that have died outside of a hospital, who have died, in various locations, be it a shelter or a bus shelter or somewhere on the street, that number is going to increase by that 55. So that's really my fear here. And that's the service that I feel that supervised injection site is providing. Did I answer that question, Dr. Krish? Or sorry, Councillor Krish?
Doctor? Yes, thank you very much. My other question is about if you could talk about what, I'm trying to not to use the word harm so many times that it becomes reductive, but essentially, I understand these heart hub models and the way you describe them today is they're not going to be able to provide services for people who use drugs. And like you said, people are going to use drugs anyways. So what does it look like when you have had a safe site for people to use drugs? You don't anymore. You're offering kind of some services still for people so they can come there, right? But then they don't have the extra ability to have harm reduction. But then this being called the harm reduction site, like, you see, the problem here is like, it seems like it's almost making the problem worse, but I won't try to call your answer in. But if you could talk about what that kind of looks like, because I'm as confused as you are, frankly.
Yeah, I completely, sorry, through the chair, I completely agree with you. I think you're hitting the nail right on the head. I agree that there needs to be continued investment and continued focus into recovery for people who use drugs. I think I agree that absolutely needs to be something that the province is investing more money. I don't disagree with that. Having said that, people are going to continue to use drugs. And what the power that lies kind of with us in terms of providing services to people who do use drugs and who are going to continue to use drugs is, can we help them to reduce the harm as much as possible? Can we help them not die from the thing that they are doing while waiting for them to be ready in terms of life circumstances to access those treatment models? So I think the focus needs to be on both. The focus needs to be on treatment, absolutely, and the focus needs to be on harm reduction at the same time, because you can't access treatment services if you're dead.
Thank you very much. Those are my questions.
Thank you. Councillor Caddison, please.
Thanks, Doctor, and thanks, Councillor Kretsch, for those questions as well. Doctor, I guess when we look at evidence and fact-based data, and I'm assuming that we all want that to drive our decisions, I think I heard you say overwhelming support in the data, the top-tier data, that there's no increase in crime, and crimes not associated with safe supervised consumption sites. Can you expand on that?
Yeah, thank you for the question. So my understanding, so again, like I said, having trained in medicine, the data that we look at tends to be coming from studies that are of the highest quality of evidence, not so much hearsay. I know that there's a lot of hearsay. I know that there's been a lot of across the country, people leveraging hearsay, people leveraging what they call uncertainties in the data. I have not seen myself any actual data that to say that here are the numbers that the crime has increased. I know that policing does tend to be increased in those areas, which again, in my very humble, just citizen's opinion, tends to be a policy decision rather than an actual issue with the crime. But that is neither here nor there. When we look at the studies, they do not show an increase in crime. That's kind of the extent to which I can speak to that, since I'm not the person who did the studies myself.
Thank you, Doctor. Councillor.
Okay, fair enough, and I thank you for that, and I'm actually, in agreement with it. So, again, you said hearsay, and I'm going to say that's like, I guess, anecdotal lived experience, and the data, there's sort of some kind of conflict there, because we have nearby residents that might tell us otherwise. So how do we square that with the data that shows us something different than the lived experience? Is there some sort of confirming bias exemplified here, or is this sensationalizing in the press? Are these factors that weigh into this safe consumption sites getting a bad rap?
Doctor.
So I think that if I'm being frank, and again, this is speaking at this point from my own opinion and kind of my own experience, I think people become uncomfortable when they see unhoused people surrounding them. And I think that leads people to be more uncomfortable. And of course, people become uncomfortable with drug use. And I understand that. And living in a neighborhood where there are encampments near me, and there have been, and I understand that discomfort. Having said that, we have to bring the services to where the people are, because what we don't want is these individuals dying when it's something that's preventable. So getting rid of that service isn't going to make people suddenly not use drugs. It isn't going to make people suddenly not live in the areas where they're living or not use in the areas where they're using. It's just going to make them use in more unsafe ways.
Okay, and then thank you for that. And this, just one final point that I wanted to stress. I think you said that sites around safe consumption supervised sites have less, what would we say, trash, needles, so forth in those areas than just areas that are, in adjacent neighborhoods? Well, can you unpack that a bit?
I mean, even intuitively, that does make sense. Again, that's pulled purely from systematic review, but intuitively that makes sense. People have places where they can dispose of their needles, where they're using in a safer space to use than they would otherwise be using, and that takes that trash off of the streets. So that's definitely a pro.
Okay, thanks. No more questions, and thanks for coming today.
Thank you.
Thank you. Councillor Clark, please.
I'm so sorry. I'm just going to move a little bit because my computer's about to die, but I'm still with you.
Thank you.
I'm listening.
Thank you, Chair, and thank you, Doctor. So can I ask, what's your direct role with the safe consumption site?
I do not have a direct role with the supervised consumption site. I am coming here simply as a physician who works with people who use drugs in my role in the hospital. I'm an internal medicine physician, and so I treat people who have had overdoses, and I treat people who have infections that result from unsafe drug use that I know these sites prevent.
Thank you. I appreciate that, Doctor. So can I ask, do you know if these sites assist people in finding rehab?
That is my That is my understanding, is that they also connect people to resources with regards to treatment. And my understanding is that the way that the provincial government is structuring these new quote unquote heart hubs is going to be specifically focused on those treatment options. However, like I said, it's important that we have harm reduction alongside with treatment.
Thank you. So do you know, after the injection in the site, how long the client stays in the site?
I'm not aware of that, given that I don't work in these sites myself.
So we don't know if people who've come in to use and have left, we don't know if those individuals, once they've left the building, have incurred any incident.
I think the doctor,
We don't know, how do we track that?
I don't know, I think the doctor has advised us of her role, that she doesn't work at a site. I'm not sure I understand if you're asking her to comment on the
Well, I'm trying to
activity in and
understand
around the site.
I'm trying to understand the statistics. It's indicating that this many people have had their lives saved. So that's individuals who were treated with naloxone at the location, but we don't know how many people have had safe injections, left the site, and then had an overdose.
I see.
Is that a correct assumption? I think we might
Doctor,
have
I
lost the
think
doctor.
you're still getting settled with your tech. If, I'll give you a few seconds perhaps. And then maybe you can, I'll check to see if you're connected with us. Elsie Goche, are you able to assist whether a connection is made?
I'll let the remainder of my questions go, Chair, and I'll take them offline with staff.
Thank you.
Thank you.
Dr. Ina, are you with us? Councillor Nan, I do recognize you as a second-time speaker, but I'm afraid we may have lost connection with the delegate.
Thank you, Chair. My question wasn't for the delegate, it was for staff in relation to the delegation.
Okay, thank you. Okay, so I'm going to assume, for those who are maybe watching us, we did have some connection issues and it was acknowledged by the delegate. So I'm going to assume that we have lost that connection. And I'm going to thank the doctor on behalf of members of this committee for her delegation and her attention this morning. Thank you, doctor. We have questions of staff, but I think before doing that, can we have a mover and a seconder to receive the presentation or the delegation? Moved by Councillor Tattison, seconded by Councillor Nan. Electronic vote in that regard, please. Just to receive the delegation. Thumbs up from Councillor Pauls. Thank you. That carries 13-0. I understand some of my colleagues have questions of staff as a consequence of perhaps some of the issues raised by the delegation, and I'll recognize Councillor Nam, please.
Thank you, through you, Chair. If I could, the reference to the pulling of the funding, the shift in the province's approach and essentially closing the consumption treatment centers here in Hamilton and move towards a heart hub model is actively underway. It's my understanding that funding applications, the intent to apply was due earlier this month, and applications are due at I think October 18th. and it is for allocations of winter 2025. So rapid announcement at the end of August. Intake is already underway. Applications are due by mid-month next month. And these heart hubs are supposed to be operational by winter 2025. Through you to staff, recognizing the rapid fire way in which the province is moving forward, wondering when there was going to be a report to Public Health Committee about the shift, the impact in our community, and what the coordinated strategy is to support these services and also to support harm reduction, if I could please.
Dr. Liu?
To the councillor, through the chair, I'm going to pass this question to Director Prieto of Epidemiology and Wellness.
Good morning, everyone. Through the chair. So appreciate the questions. So we certainly have begun those discussions both at the Hamilton Opioid Action Table as well as through the Hamilton Drug Strategy Steering Committee. So as we begin to understand a little bit more from the province and the direction, we really are engaging in conversations to really talk about the impact of these closures on the community, to look at some mitigation strategies when we try to address the risk, of course, of increased public use. And so talking about how do we help individuals access, for example, harm reduction supplies, have conversations around naloxone, not using alone. So some of the really important health messaging. And also really wanting to understand with our community partners as well around, what additional services potentially are required within the community.
Sorry, if I could then as a follow-up through you, Chair. So the additional services that may be required in the community. So in recognition of the closures of the CTSs, is that an analysis? Like, we already know that these services are needed in our community. We know from public health's reports previously the impact of these services. I guess I'm just kind of curious about next steps and when this committee might receive an update.
So through you, Chair, to the councillor, really when we're talking about services, it's the importance of ensuring that we are able to provide harm reduction supplies and that they're sort of available in the community as well as naloxone. As far as when we're coming back to committee, we haven't landed on that yet, but certainly we'll be bringing a report back and also wanting to look at our opioid action plan and where we are to date with all of the actions identified in there. So this will be part of our work around addressing harms and deaths associated with opioid use in the community.
Councillor?
Sorry. So we don't know when the report is coming, just to be clear. Thank you.
I think we heard it's a work in progress and they're trying to tether it to the opioid strategy. Thank you. Any further questions? Oh, sorry, Dr. Liu.
To the councillor through the chair, just to add, the consumption and treatment services, the framework and process as outlined or provided by the provincial government is a mechanism through which exemption to the Federal Controlled Drugs and Substances Act is applied. While the funding applications for the new HEART model has opened, there's not yet been any legislation or regulation tabled by the provincial government. So there's still a bit of an evolving landscape around the mechanisms through which some of the discussed policy interventions may be applied, which would be an important consideration to what local implications to services may be.
Thank you, Chair. Doctor, that was helpful. So through that, then, recognizing that changing landscape still, are we, through the tables that were discussed or referenced, clear about how many applications we're anticipating in the city of Hamilton for a HEART Hub?
To the councillor through the chair, and pass that to General Manager Mader.
Through the chair, Grace Mader, General Manager, Healthy and Safe Communities, to Councillor Nan. To be perfectly honest, it's been a very confusing process that the province has outlined with regards to heart hubs. There's been misinformation provided both to those agencies that are currently providers of the consumption treatment sites, as well as through our Greater Hamilton Health Network. And so and the opportunity that Melissa happens to be here today is very, very timely because she and myself and Dr. Richardson, we had been working very hard on trying to determine what the best approach was for the City of Hamilton when it came to this submission. We've been clearly told on a number of occasions through a number of staff that Hamilton would be considered to have one opportunity. There was concern amongst a lot of our partner agencies that this was an opportunity to submit more than one application. The concern was about the ability of then just ending up pitting the two applications against each other. We are supporting the Urban Core Health Center with a submission. That was the pre-application went in, as you'd indicated, Councillor, on the, I think it was the 21st or something of this month, with the full application then going in on the 18th, and we're continuing to support that. We're also continuing to explore every opportunity that if there is in fact greater opportunity for us to submit more than one application without putting that original application at risk, we're certainly going to be continuing that. Thank you.
Thank you for that, General Manager. Really appreciate the clarity.
Councillor Critch.
Thank you, and that answers one of my questions, and I'm glad to have it on the public record that there's going to be sort of a single application sent forward for now, that you're supporting the existing folks who are already doing this work in our community. That I think will resolve a lot of the chatter I'm hearing about, to be honest with you. So thanks for saying that. My questions for you are about the city's role. So I think you just defined that, though, not to get you to repeat yourself. I think the city's role, I think you're saying, is that we're there to be able to support as a city applicants to the provincial government, and we can assist by providing that support. Maybe it's just a letter of support saying, hey, we think these folks will do a good job. Is it more than that?
Through the chair, the requirement was that the service system manager for housing must support the application going in. And so we did offer our support to that application. It was verbal, and it was, through the, and was included in the pre-application, and there'll be a more formal approach, I'm assuming, in the next rollout.
About a year ago now, we had folks from the YWCA come forward to make a presentation on safer use spaces. And so I know that, of course, that model exists, and that's, if I have it right, through the federal government, they are funding, some of the funding for that model exists, the federal government. This is, of course, a provincial program. Just want to untease a little bit some of the things that the doctor was mentioning during her delegation about regulatory framework. And I'll just give you my basic understanding, and maybe you can tell me if I'm right and fill the gaps in. My understanding is this is heavily regulated by the province, and the province has made a decision quite clearly that it's moving in a different direction than it has been in the past, firstly. Secondly, there are some other things going on with the federal government in terms of some funding, but no matter what, we require an external agency to the city to actually want to apply for those things, and we can support them. The city can't itself be doing these things without a partner. Does that sum up essentially where we're at?
To the councillor through the chair. So the CTS, or Consumption and Treatment Services framework, is both an exemption to the Federal Controlled Drugs and Substances Act in terms of the ability to operate those services, as well as a model for funding from the province that was flowed through. That is a model that has been operated by the provincial government for a number of years at this time. Even prior to these announcements at the end of this summer, applications for new CTSs had been closed for some time. In contrast, a urgent public health needs site directly from the federal government in terms of exemption from the Controlled Drugs and Substances Act does not carry with it the same level of funding and other sorts of program or process support that existed through the CTS process, and where those sites have operated, they've typically had to access funding through other means. There is, in the between those two spaces of the provincial government and federal government, there's still, I think, some uncertainty around what this announcement means in terms of sites that are not operating under the CTS banner or umbrella, which is what I had alluded to a reference in terms of no legislation or regulation has yet been tabled by the provincial government to that effect.
Thanks, and you've hit on my last question, which is about the difference between the regulation and the funding itself. So let's just maybe park those things separately. Let's just say that there was just an abundance of money to be able to support these kinds of sites, and that wasn't an issue. And even let's just say the city had a reserve fund that could use to help with some of the funding. From a regulatory perspective, where are we at in terms of needing permission and from whom to be able to do these kinds of things? I understand the province, we of course require permission for them to apply for this Heart Hub thing, and I understand that. But in terms of the federal government, what avenues exist for people to apply to have services that are similar perhaps to what the YWCA is offering? From a regulatory perspective, not from a funding perspective.
To the councillor through the chair. Exemptions under the Controlled Drugs and Substances Act can be applied through the provinces as a class exemption, which is the way that the provincial frameworks have been set up in terms of any sort of supervised consumption sites. But individual agencies may apply directly to the federal government around an individual exemption to the Controlled Drugs and Substances Act.
Thanks, and a comment if I can. I was there for the announcement of these Heart Hubs when I was at the Association of Municipalities of Ontario conference. And although we had heard whispers in the hallways of the conference that this announcement would be coming, we didn't know the contents of it until it was announced there. And if folks are interested, they should go and look at the government's website where there's a fulsome description from the ministry about what these are. Mind you, it lacks the necessary regulatory rigor that will come with actual legislation, but it's very insightful about the kinds of messaging being sent around this. It's saying things that aren't necessarily based in expert opinions, don't match up with what the doctor said today, and frankly are quite dangerous and scary. People in our community keep saying to me, I hear them saying all the time, we don't want to see folks forced to be using drugs in public for all kinds of reasons, right? You can come up with your own reasons on why people feel that way. When we don't have safe spaces for them to use drugs, they're going to have to use them in public more often. So all the things that you may be hearing as a counselor, or I'm hearing as a counselor about drug use in public are only going to be made worse by this decision, not better. And so I think that we have to think about that and reflect on that when we think about how we're applying to these new services, how we speak critically about this. I'll leave it there for now, but thank you.
Councillor Clark.
Thank you. I'd like to start with what I thought I heard Dr. Liu say, was that there was no legislation or regulation announced as of yet. So there's nothing draft that's been floated out there. It's just in the ether, and here's where we're going. We being the province, not us.
Doctor.
To the councillor through the chair, the press release and announcement by the provincial government did indicate that there was a legislative portion to what has been announced. That, to my knowledge, has not yet been tabled.
I'm equally confused then, because the provincial government cannot spend money on a new program without the legislation being enacted through the House. And the regulations come out specific to the legislation. So we really don't know what's going on at Queen's Park in terms of this process at the moment. We've had a press conference, a lot of talking heads talking about it, but we've not been provided, here's how it's going to work, and here's the rules. Is that correct?
Lots of press conferences. Go ahead, Doctor.
To the councillor through the chair, we have the information made available to all community providers around the process through which a Heart Hub application may be made, but no sort of other details to my knowledge.
So is Hamilton only receiving one Heart Hub application?
I'll pass this question to General Manager Mader.
Through the chair, that's what we have submitted for one at this point in time, yes.
And what process did we follow to determine how we were going to proceed with endorsement of an application?
So as Dr. Liu said, that the information went out to all health providers, and they were the ones who have the ability to make an application. You must be a health provider in order to be the lead for the application process. The current CTS site, the Urban Core had reached out to the city, and we've worked with the leadership table there about what their plans were and how they were going to be looking for partnerships to ensure that the delivery of all the requirements were going to be met. And they pulled that together, and they asked us to support that, and we agreed to it.
But had we heard from anyone else?
Through the chair, we had been working with Greater Hamilton Health Network, who brought all the providers together. And through our connections with through the Ministry of Health, the indication was that there would be only one application would be looked at for Hamilton. And so therefore, we didn't want to get into a competition of having multiple applications in. We were trying to bring this as an opportunity for the community together to work collectively on how we're going to best deliver this for the community.
But there will only be one location for the Heart Hub?
Through the chair, do you mean like one physical location?
Yes.
So part of the opportunity is how that can be delivered through the community, about where it would be applicable, where the services could be actually delivered. All of those things, I think, are still in the process of being determined with the collective group that is responsible for it.
So if the YMCA or the YWCA or Mission Services or any private program that's outside of our purview wanted to be a part of this Heart Hub, how does that work? Are they forced to compete with each other?
Through the chair, that's where we're recommending that they work collectively together they have one lead agency, but that lead agency can have multiple partnerships in order to deliver the services.
Okay. Can I ask, I might be out of time, can I ask one more question? So I'm trying to understand, and I've heard this from a number of residents, what actually happens when someone goes into a harm reduction site for safe injection? They come in with their drugs. Are their drugs tested?
Dr. Liu, would you like to walk us through that?
I'll pass this question to Director Prieto.
Oh, thank you.
Thank you. Through your chair to the councillor. So I certainly will speak from what I understand from the organizations, again, noting that I am not there regularly as well. So drug testing is available to individuals prior to using, so it's certainly not something they have to do, but it is an option for them to test the drugs prior to. And then they are able to access a space where there are clean supplies available. And then there are professionals as well who are there to monitor and to be available. One, to answer questions, and two, in the event that there is some sort of incident after use. I will note as well that our understanding is that staff are also available to have discussions around treatment, to have conversations around where individuals are at, as the doctor had indicated on that, on their sort of pathway towards recovery, if that's what they're looking for. After they use, we understand there's space there for them to stay. And so again, it's for that monitoring purpose in the event that there was an incident. And of course, there's a naloxone available if needed.
Thank you. I'll come back on for a second time. I have a couple of extra questions.
I think Dr. Liu would like to add.
To Councillor through the chair, just to add that the CTS framework, as it has been implemented by the provincial government, did include pathways and wraparound treatment, medical treatment through the healthcare system as a necessary element of sites operating under the CTS umbrella or framework. And then secondly, just wanted to add that supervised consumption in any way, shape, or form is one element or one approach of a harm reduction philosophy, and there certainly are many different approaches or avenues that are applied in harm reduction generally in its aim to reduce the health harms associated with substance use. And Public Health Services harm reduction program has worked in parallel with the operator of the CTS for quite some time, but does engage in programming intended or aimed to reduce health harms associated with substance use, separate from supervised consumption in any of the frameworks or approaches that they are applied currently.
Thank you, Doctor. Are there any first-time speakers on here? I'll recognize Councillor Pauls, and then we'll go back to Councillor Clark. Councillor Pauls, please.
Thank you. I want to be clear what the new hub support is. They're not saying they're taking away the safe injection, but my understanding is they're using a more comprehensive, holistic approach to harm reduction. So if we do close the safe injection site, we're opening these new models which give more support. So that's my understanding.
I think I know the answer to that. It's an important point of clarification for us to be clear on there, but I'll ask Dr. Liu to outline what the practice will anticipate it to be.
To the councillor through the chair, from what we have been made aware of by the provincial government, the intention of Heart Hub sites is to not include supervised consumption or distribution of other harm reduction materials, at least in terms of what information has been made available so far.
I remember last year in Toronto, the safe injection, there was an incident that a bystander was, shot at because there was some crime surrounding the site, a safe injection. So my understanding is this new hub is to prevent maybe dealers to come around and have more holistic. That's what I understand, that it's not just a safe injection site. It's all encompassed of it. And that's my understanding, but you don't, as I hear that you're saying they're not allowed to do safe injection site in the hub?
I believe that is the case, but I think it's worth further clarification.
Yeah.
Dr. Liu.
To the councillor through the chair, it is our understanding that supervised consumption is not a permitted element of the Heart Hubs as they've been outlined.
I didn't know that. I thought it was a new model to replace traditional safe consumption site. So it's to enhance it, to make it safer and all. So that was my understanding. Thank you for clarifying that. Thank you.
Okay. Councillor Clark.
So just to be clear, the new program is not enhancing what was there. It's changing what was there.
To the councillor through the chair, it is quite complex in that there actually are still some CTS, consumption and treatment services across the province that did not fall under the geographic restrictions as outlined by the provincial government, that being their proximity to schools or childcare centres. And at this time, it seems that those sites that did not meet that threshold will continue to operate as CTSs, while in parallel applications for Heart Hubs have opened with the expressed intention for those sites that are impacted by the geographic restrictions as outlined by the provincial government to have an initial opportunity to apply for a Heart Hub prior to other service providers, for example.
And so to clarify further, the province created unilateral radial separations around a safe injections location site. And if it's hitting that distance for schools and daycares and long-term care facilities, then that location has to close because of the geographical location, not because of what they're doing.
To the councillor through the chair, yes, that is the how the sites that
We're targeted.
were identified that would not
I
be
use the
permitted to
term
continue.
targeted, doctor. I know it's more political, but, so can I ask, we've heard about the Heart Hub, and we're doing that application process with a number, but is the city of Hamilton now prohibited from having a safe injection site, a CTS somewhere else in the city that might hit the might meet the radial separation?
To the councillor through the chair, the city itself has not been the operator of a consumption treatment site, but as I had previously mentioned, even prior to this most recent announcement, applications for additional CTSs have been closed for some time. So even if an organization wished to open a new CTS, that would not have been permitted. And from what has been publicly announced or discussed around this recent set of closures, it's my understanding that sites will not have the opportunity to move to a new location.
Thank you. And the last question I have, and it's an important one because as I think the chair indicated, there's lots of misinformation out there about what is, what isn't, and it's very confusing when you don't have legislation or regulations to say, oh no, this is what they're doing, because we're basically pointing to a press announcement to say, that's what we're doing. So when we're dealing overall with this program, we needed I'm struggling for the word, but it's basically an exemption from federal legislation, the criminal code specifically, so that these operators who are running these safe consumption sites, their staff do not get charged with administering a narcotic.
To the councillor through the chair, yes, that's the process for an exemption under the Federal Controlled Drugs and Substances Act.
And that exemption does not exempt that facility from buying narcotics and giving out narcotics.
That is not my understanding as a part of that exemption.
So they're not permitted to hand out narcotics.
They're not permitted to hand out narcotics that are not being provided through prescription through other sort of healthcare mechanisms where a controlled drugs and substance may be prescribed by a provider for any number of reasons. And so that does not relate specifically to the operation of those sites.
So someone gets a prescription for OxyContin, they go to that safe injection site. It's not an injection, it's a pill.
So that would not be a part of the services provided there, but I can't speak for whether, for example, a pharmacy may be in the same building or next door to a site that might be operating.
So my question intended was to clear up some confusion, and now I have some confusion. So are there individuals in the city of Hamilton, maybe doctors, who have been exempted from the criminal code and they are enabling drug addictions and handing out safe drugs to their clients, their patients?
Through the chair to the councillor, I can't speak to every physician within the city and what their practice would be, but the regulatory college for physicians does outline specific requirements that a physician must adhere to in terms of maintaining good standing with the college. The Controlled Drugs and Substances Act relates more to the possession of, for example, illegal substances by individuals rather than providers who might be practicing within their scope.
And so that goes back to my original question. Someone comes in, here's the medication the drugs that I purchased on the street, they're illegal. I'm going to inject them. The role of the safe injection site is to assist, but they're not providing narcotics. It's narcotics that the patient is coming in with. The only one that might be provided is if they're helping someone on rehab where they're being weaned off certain medication, drugs.
Through the chair to the councillor, yes, that's my understanding of how the CTS framework works. I can't necessarily speak to how sites may operate in other jurisdictions outside of Ontario.
Thank you. It's much clearer, but it's important that folks understand that was the purpose, to help people who are taking black market drugs to prevent them from poisoning themselves because the drugs that they purchased have been laced with stronger drugs that they didn't know was in there. And consequently, they have an overdose from that poisoning, and naloxone is administered and saves that patient's life, correct?
To the councillor to the chair, that is correct. I will add to say that not every overdose would necessarily require intervention with naloxone, and for example, supportive care such as monitoring or oxygen may also be applied, and that would be a part of the element of having individuals trained in this area available to monitor someone who has recently consumed a substance.
And we don't know yet exactly what the province is doing because it was just a press conference. Thank you. That was political.
Thank you. No further speakers. Thank you to staff very much for that. Dr. Liu, I believe you're here to introduce our presentation, 8.1, which is called Collective Impact, Healthy and Safe Communities and the Greater Hamilton Health Network, a 2024 update.
So thank you, hello everyone. You've had a chance to hear from both of us already this morning, but myself as well as Melissa McCallum as the Executive Director of the Greater Hamilton Health Network are quite excited and pleased to be able to be here to provide an update on the ongoing work of the local Ontario Health Team, the Greater Hamilton Health Network, as well as the intersection between that work as well as the Healthy and Safe Communities Department. This is an annual joint presentation where we'll share some updates as well as highlight some of the work that has been done over the past year. So we will be covering today the health system transformation in recent years, including the current structure through which Ontario health teams are operating, the evolution of the Greater Hamilton Health Network since the last time that this information was brought to the Public Health Committee, some of the partnerships being worked on collaboratively through the Greater Hamilton Health Network, including including Healthy and Safe Communities with the City of Hamilton, and some examples of some of the collective impact that the Greater Hamilton Health Network and Healthy and Safe Communities Department have been able to achieve since the last time that we brought this presentation to the Public Health Committee. I do want to note and highlight that part of this work does include the work of the Physician Retention and Recruitment Program, which was brought forward in correspondence earlier this meeting and already discussed, and so we'll not be bringing too much additional information on that particular topic for this presentation. And I'll hand things over to Melissa.
Thanks, Dr. Liu. I wanted to provide a quick overview of the health system transformation that's happened within our province over the last few years. I spoke a little bit to this when I came last year, but just as a reminder, we've gone under a significant change in how we've organized health services and the planning for health services within our province. And that change really started in 2019 when we saw the LHINs, the 14 local health integration networks, dissolve, and a very large provincial organization called Ontario Health develop. So this change also saw that local planning, which the LHINs were responsible for to some degree, but a larger geography catchment, for example, Hamilton was part of Hamilton, Haldimand, Brant, and Niagara, now saw that Hamilton's planning would come a little bit more hyper-local. So Ontario health teams were designed to make sure that more local initiatives and programs were designed compared to the larger catchment of the former LHINs. You'll see in this slide that that past system really saw Ministry of Health, underneath that the 14 local health integration networks, and then underneath that is all the health service providers. We are now moving over to a system where the Ministry of Health is still the steward of the resources. Ontario Health holds the funding and accountability, but Ontario health teams are really that convener around local shared problems and collective action. So Ontario Health Teams and the Greater Hamilton Health Network is one of these teams. As of January of this year, the full province is now covered by an Ontario Health Team. They were approved in waves starting in 2019. Hamilton was approved in the first wave of 24 in November of 2019. Now we see 58 across the province. I should mention, though, at the beginning of the Ontario Health Team journey, Hamilton applied and was successful in becoming a Hamilton Health Team. But since then, our ministry has asked that Hamilton incorporate a larger geography. So we see that Haldimand and a portion of Niagara Northwest in and around the West Lincoln Hospital system now become part of the Hamilton team. We then rebranded in 2021 to the Greater Hamilton Health Network, and that's more reflective of our larger geography. So we're responsible for working across health and social providers and really being that convener around health and social issues for the system. We bring together a diverse and large set of partners to have these discussions. Our Ontario Health Team is actually the second largest in the province based on population. Our attributed population is close to 800,000 residents. The largest one is Mississauga, close to 1 million. We see large geographically based teams, especially in the north. So the Ontario Health Team model has been maturing over the last 4 years. As you can see that, even teams and locations that did not have Ontario Health Teams started to have them over the last few years. So we're all kind of at different starting points. Hamilton and the Greater Hamilton Health Network is seen as one of those more mature teams. And the evolution of what's next to come in the Ontario Health journey is still honestly being worked on. A lot of it is around improving patient care and the coordination of services, but we're moving on a continuum that sees Ontario Health Teams reaching what the ministry calls as designation. And designation is a Community Ontario Health Team being responsible for an integrated funding envelope. Right now, we do receive funding, which I'll go over, but how do we actually manage population health funding from this level? And that's really how we're moving towards maturity as an Ontario Health Team. All of this information and what we're responsible for is outlined in the Connecting Care legislation, which was introduced in 2019. At maturity, what you'll see in this slide there, we've broken down, and please note this is our slide that we've designed along with public health, to show a bit of the relationship between all of these models and all of these kind of governance structures that we have currently. Ministry of Health is the, again, steward of the funds and creates those accountability agreements. Ontario Health holds those funds right now, but it is Ontario Health Teams that's working with local providers, including hospitals, community supports, long-term care homes, to better understand and really filter and bubble up, well, what's important for the Greater Hamilton area? You know, how do we have that stronger voice when it comes to funding and accountability? A really important thing happened in September of 2023. The Greater Hamilton Health Network was announced as one of 12 Ontario health teams in the province that will work towards an accelerated work plan. We were assessed based on partnerships and the work that we've done to date, and they are moving through these 12 teams faster in terms of working. What does designation look like? What does holding funding envelopes as an OHT look like for a community? So we're really proud to be part of that work. Here in the West, we joined Burlington and London as one of those 12 teams. The rest of them are scattered across the province. So to support this accelerated work plan, we have a mix of both provincial dictated priorities and local priorities. You'll see them on the screen here. A lot of this has to do with navigating the health system, bringing providers around shared complex problems, a large amount of work in primary care, which we'll speak to. And at that same announcement in September of 2023, the ministry also said that over time, home care responsibilities to some degree will actually land in the Ontario Health Team model. So that's something that we are starting to prepare for right now. It's important to note that, we are a small and mighty team. 8 full-time staff and 2 part-time staff get up every day and think about the Greater Hamilton Health Network. We have a base funding model that is actually consistent across the province for all OHTs, depending on what your population is, of about 750,000. As being part of this accelerated work stream, we do receive additional funding. So this year we will have an accelerated funding package that's to be determined. But actually, what's been really incredible about the Ontario Health Team model is that we've been able to work locally with providers to also advocate and ask for more funds for our community. Over the last year, we've been successful in bringing $5 million into the community that's focused solely on priority populations. In terms of partnerships, we are developing and strengthening a lot of local partnerships. You'll see some of them on the screen. The ones that are starred are in alignment with the Healthy and Safe Communities Department. You know, public health and the municipality has been a very strong partner of the OHT since the very beginning, which is actually not as common as you think. We are often actually commended on the fact that we are so close and aligned in our work. But you'll see that the services span the continuum, and that's extremely important. We're in the business of integrating care, and we need everyone at the table. You know, what's not on this screen is actually even smaller services and non-health service providers that we work with, which is honestly a very important part of the work. Every Ontario Health Team can determine their partnerships. We've taken the opportunity to be very vast in our partnership development. We do not limit it to just health service providers funded by our ministry. We work along housing, we work with charities, we work with churches. If you are part of being, part of the solution of providing care, the OHT is wanting to work with you. We have a very, very open membership. As of this summer, we have over 70 partners working in all of our working groups. So it's been a huge collection of work over the last 5 years. Pass it over to Brendan.
So as Melissa has just outlined, the Greater Hamilton Health Network and really all Ontario health teams really benefit from and need to engage with providers across the entire continuum of care to ensure the coordination of the services across the system. So when we think about the continuum of care, us in public health are very fond of this analogy to compare it to a river where there's an upstream, a midstream, and a downstream part. And so those members and partners of the Greater Hamilton Health Network provide services at differing parts of the river spanning the course of a full continuum of care. So those downstream services are often those that are focused on addressing or treating immediate health issues. And these are most commonly medical interventions, things such as prescription of medications, assessment by a healthcare provider, performing a surgery or a procedure. And these are the things that we often think of when we're thinking about the healthcare system. Midstream services or interventions are more focused on addressing the risk factors that lead to health issues and what can be done to mitigate or prevent them, to prevent poor health outcomes. And so thinking about things like programs intended to increase or improve the nutrition or physical activity of the community, or connecting someone with the necessary supports to be able to access adequate housing would be relevant sort of midstream interventions. And then finally, upstream services are more focused on the structural or system level issues that we know impact and determine health and can perpetuate health inequities. And so implementing policies that, for example, influence income security or advocating for access to gender affirming health services, for example, would be upstream approaches to improving health and addressing structural or systemic barriers or determinants. And so as you can perhaps see or understand, the further that you go downstream, the more focused that you are on individuals, and the more that you move up, the more that the focus is on communities or populations. And so another example that we can use to really understand this spectrum is looking at chronic obstructive pulmonary disease, or COPD, where people with COPD are often short of breath, can have quite productive coughs, wheeze, are very prone to respiratory infections, and that can progress to the point of needing, for example, support with oxygen on a daily basis. And the most common determinant of COPD is a past history of smoking. And so the downstream intervention, the healthcare system is concerned with treating this with medications and puffers and providing medical interventions as a disease progresses. Midstream intervention might include those affordable smoking cessation supports and engaging with youth to prevent smoking initiation as a means to reduce or prevent COPD. And finally, upstream, there may be policies that influence how much smoke somebody may be exposed to in the environment, secondhand smoke from cigarettes in public places such as restaurants or parks, for example. And so to really address a health issue, an approach all the way across the spectrum is impactful and needed. And so with that same sort of framework or understanding, with the Greater Hamilton Health Network, Healthy and Safe Communities and public health have a unique role, particularly more focused on those upstream approaches to promote health and prevent disease across the population and the community, which is a bit unique and in contrast to, for example, many of the other partners whose primary role within the system relates to primarily direct service provision to individuals, for example. And so the Healthy and Safe Communities approach or role really does complement those other GIN partners by focusing on the health and well-being of the entire community rather than individuals, and really engaging with providers around some of those population health elements, and really focus on preventing disease and injury, for example, to promote overall health and well-being. And so I think it's a really important point to emphasize that Healthy and Safe Communities' role is primarily at that upstream to midstream level, and where we do provide direct health care services to individuals, it is with an intention or purpose around prevention primarily, as well as a focus on those populations that are disproportionately impacted by particular health issues or in a attempt to mitigate or reduce health inequities. And so by really ensuring that the GIN has partners that are focused and experts in upstream, midstream, and downstream approaches, it really enables to have an overall comprehensive approach that improves the health both of individuals as well as communities as a whole. And so since the development of the GIN in 2019, as Melissa had mentioned, there's been some really strong linkages and partnership efforts across the Healthy and Safe Communities division, including public health services. And this partnership continues to evolve and grow as the roles and responsibilities of the GIN increase, as Melissa has described and alluded to. So there's there's three significant ways just to highlight that we're able to leverage that upstream approach through the GIN's work, and that is the involvement in the governance of the Greater Hamilton Health Network. And so Healthy and Safe Communities General Manager as well as the Medical Officer of Health serve on the board of directors for the GIN. Participation in many of the councils and working groups of the GIN, including providing expertise and input around planning, implementation, and evaluation of initiatives of the GIN. And that includes representation from public health services, paramedic services, housing services, as well as the Lodges Division. As well as the submission of a joint report to Public Health Committee annually, which you're currently listening to, sharing updates and highlighting some of those collective impacts. And so the direct connection between Public Health Committee or the Board of Health and the GIN is through the annual report to committee. Pass things back to Melissa.
So we're going to talk a little bit about a few key examples of how the GIN has progressed work over the last 5 years. So the first is that I do want to mention that, health equity is a foundation of our work. We apply health equity principles to all aspects of the GIN work, including identifying, what populations are we going to work with first. We've done large-scale engagement, including a health equity framework at the beginning of the OHT journey that actually helped consult not only our governance model, that it was, diverse and equitable, but, who actually needs our care and collective action the most. Our Health Equity Council, which is a formal council underneath our board, helps provide the infrastructure for that work and has diverse representation. So, just looking at health equity as a focus for this year, we have quite a lot of initiatives, 4 of them being, we are very focused on an equity-driven funding model. And this is about supporting populations and organizations to really rise up and be at the forefront of investment planning. I'm sure many of us would say that, small organizations actually don't have the infrastructure to put in ministry proposals or grab data. So we do this as a collective to lift up some of those smaller organizations that are doing amazing work for equity-deserving populations. We've been successful in that funding for a number of groups, for transgender diverse individuals, Black health, and those who use drugs. This year, we were able to provide language accessibility services to all of our primary care providers as being, a very key determinant of improving not only the translation and interpretation done by family members, which we know can be harmful, but making sure that when you do have an appointment, you're having that appointment in the language of your choice. We are soon to release a positive space assessment toolkit, and we are advancing, along with a lot of our other organizations, how to collect health equity data. I do just want to mention, part of this work is really around education and awareness. The GIN, along with Urban Core, actually created a video as part of Harm Reduction Month to walk through a CTS. What does it look like from the moment you enter the doors to the moment that you leave? So that's available on our website. It's part of, increasing the education and awareness around this, so encourage you to check that out. Another really great initiative is our High Need Community Initiative. We were able to secure $1.4 million last year to work across 10 organizations to disperse this money. It collectively identified priority populations from our health equity report. The funds were used across a number of organizations that served refugees, newcomers, individuals experiencing homelessness and mental health and addictions. Healthy and safe communities were a big part of that. They were able to receive some funding through this initiative for dental care for children. And as part of harm reduction, we are going to be opening up 3 health boxes in this city. 2 will be at Mohawk College, 1 will be at Hamilton General. These are 24/7 harm reduction vending machines that you will be able to get supplies from around the clock. This will be the first of its initiative in this region. We spoke a little bit about primary care, but primary care is a very important part of our work. As we said, the best data tells us that at least 70,000 people within the Gin catchment do not have a primary care medical home. We also know that there are so many different models of providing primary care, so how can we bring that together and unify that voice? So this is a key and vital part to the Ontario Health Team work. At this time last year when I spoke to the committee, we had actually just put in a very large proposal to the Ministry of Health to expand team-based care. We didn't know at that time if we were successful. We did receive a small portion of what we asked for, $2.2 million, this February. This is an actual really important investment. It's the first time that providers across the Greater Hamilton area came together as one. There is one unified vision for how we are going to attach people to primary care services in this city. We were the only region in the province to hand in one application. So we've started already to get these investments to work. Staff were hired in May, and since then we have close to 1,300 people already attached to a primary care provider, and that is with a focus on those equity-deserving populations. Healthy and safe communities is also a big part of this work. We work together in doing large-scale clinics and events. We do and still commit to doing once a season large-scale women's homeless drop-in clinics, which has actually been recognized at an international stage as being a clinic model that co-locates a number of services for women to provide in a low-barrier way. And honestly, I think I'll end with one of the best tangible examples in the last month is that last week we opened the doors and did the ribbon cutting to healthcare at Ever Rothwell. This is the first primary care hub that we are collaborating with the Hamilton Family Health Team and many of our GIN partners to open up primary care access in a team-based way to those who need it most. So the Ever Rothwell Center partnered with us and the Hamilton Family Health Team. It actually soft launched in June to serve people in the L8L postal code to attach them to primary care services. As of last week, over 200 people had already been attached to the center that provides interdisciplinary services, not just primary care. And we're looking to expand this model across the city, bringing primary care in a team-based way to geographical locations. So this was a really, really good news story from last week, and the center continues to attach clients with the hopes of attaching 1,000 by next year. So, we continue to evolve. All of this work depends on the collective work of our organizations and partners, which have really stepped up and come to the table. We've been able to accomplish a lot, especially with, the complex issues within our community. And we definitely stand by an all-of-society approach. Our Ontario Health Team will work with anyone who's willing to work with us to provide innovative problem solving for the city. So thank you so much for allowing us to take the time today.
Thank you very much. We do have some questions, but I think it's only fair to, if you'd like to go back to your seats and take a load off and have access to your material perhaps as well. So folks know we have Councillor Wang followed by Councillor Nan. Councillor Wang, just a few more seconds for folks to settle in. Okay, thank you. Councillor Wang.
Chair, I have 3 questions, and some of them may be a little bit lengthy in answer, so I wanted to set that stage right ahead that I have 3 questions I'd like to ask.
I'll sit down then.
My first question is, as it relates to slide 16 about the primary care network, I know we have heard a lot already about the primary care network and the physician recruitment. I wonder what is being done about, say, registered practical nurses and how they are contributing to the primary care network and the team-based approach that both ED McCallum and Dr. Liu had spoken about.
Excellent, thank you. Who would like to take that? Executive Director McCallum.
Hi, through the chair. So great question. Our primary care network is not inclusive of just family physicians. It is the team that wraps around a primary care model, which is nurses, it's physio, it's pharmacy. So our primary care network has a membership of all of those people that provide that support. And, you know, so much of, I think, what you heard today was around that team. We don't have enough doctors. So we need to depend on that team to do what they can in a model to free up space as best we can for physicians to take on and roster new clients. So yes, you'll see some primary care networks in the province that just focus on physicians, and we have not taken that stance.
So a supplemental to that then, through you, Chair, is how are we supporting, say, registered practical nurses? I understand that they are part of that network. They may, they do provide a little bit of that substitution for certain primary or family care. So how do we attract and support and continue to retain talent like that? So it could be in PSWs, it could be in nurses, it could be in RPNs, it could be in physicians. What are we doing in order to attract and retain that level of talent to keep them here in Hamilton?
Through the chair. So, you know, we don't have enough of those either, right? Of those employees. So a part of what we're doing is creating a model for the team care. Because just like physicians, PSWs and nurses don't necessarily want to work alone either. I will say we are very challenged by pay equity in the community. We lose nurses and physio all the time to the acute care sector. We need to see wage equity in the community sector to keep these staff there. It has not been fair that we have not accommodated staff to work in the community. Patients receive the most amount of care in the community. So we need to make sure that that workforce is healthy and thriving and wanting to stay there. And that is, you know, we are starting to work with our local MPPs, our ministry, about how we advocate for that. Because if we do not have a primary care system that is thriving, all of the other acute care systems will continuously be even more stressed than they are right now. So we're trying our best to build up, you know, a team model. We need that support from our ministry to pay community staff at an equitable wage.
Thank you. Chair, my second question then is relating to slide 10, where Dr. Liu spoke about the example of COPD from the downstream to the midstream to the upstream. One of the areas that I'd really like to ask for their commentary on is the upstream area, especially because today in wards 3 and wards 4, we have a significant air pollution and particulate problem, which anecdotally, again, I don't have all of the answers there, but anecdotally, we are hearing a rise in respiratory distress as well as COPD. How would GIN help with something like that? And how do we put that into the equation, especially because that they're also a part of the Healthy and Safe Network, Healthy and Safe Department as well?
Mm-hmm. Dr. Liu?
To the councillor through the chair, I think this is an example of where the core work of public health as a partner to the Greater Hamilton Health Network is really an opportunity. And so there's quite a lot of work that public health does around air quality, but also around enforcement, for example, of bylaws around smoking, availability of tobacco and cigarettes. And so these mechanisms through which we engage with the Ministry of the Environment, for example, that are avenues and channels that healthcare providers or health service providers are not necessarily the ones best positioned to engage in that work. And so I think it highlights that as part of a whole, each individual partner has core work and roles and responsibilities. That's an opportunity to engage in prevention and upstream work as an example.
Thank you for that answer, Doctor. I suspect that myself and Councillor Nan will be reaching out to yourself as well as Edie McCallum on a follow-up meeting to discuss just this very much too. Last question is, on slide 6, when we speak about the health system transformation, of which you speak about the accountability agreement and how funding potentially works, how does hospital capital funding work in this instance? Are you only speaking to just the operational? Because I do recall, Chair, that we've had both hospital systems here in Hamilton come and ask this council to get ready, that they will be asking us for a large capital investment. So how does that work?
Through the chair, the Ministry of Health has a capital division that they would deal with directly.
So then Jen would have no say or advocacy there at all?
The GIN could be part of planning and convening around the need, but it would ultimately be the Ministry of Health's division that would sign off on any capital development.
Thank you. Those are all my questions. I really appreciate the amount of work that went into this. Thank you.
Thank you. We have Councillor Nan, followed by Clark, Taddison, and then Danko. Councillor Nan, please.
Thank you, Chair, and thank you to the doctor and Executive Director for the presentation. And a big congratulations to the partnership. The $5 million in successful funding is a significant contribution to our community. The 2.2 million specifically for primary care networking is so essential when there are so many residents in our community who put off seeing a doctor because of the lack of access, right? And when they really ought to go seek some medical advice to deal with whatever they're contending with. And often it's not until the problem gets so extreme that they end up in the hospital to actually access some care and support. And so, you know, that upstream piece is so critical, and really appreciating the way in which the work has been centering health equity and those priority populations that have been historically and systemically left out of access. And then tending to it, right? Like not just naming the inequity, but investing in solutions that bring access right to those communities that have been historically and still remain disconnected from the care that they deserve. So congratulations and thank you. And it was absolutely so heartwarming to be part of the launch last week at Eva Rothwell Center for the LA postal code specifically. 2 questions, if I could, Chair. One was the health boxes. So these are exciting and new. Executive Director McCollum, you mentioned that they're yet to be launched.
Through the chair. Yeah, I think the Mohawk box should be done this fall and opened up to the students to be accessed there. We are still working with the Hamilton General for some minor renovation to get that one up and running.
Thank you. And then in the report, if I can, I only have one question on the report. Is it okay if I ask it now, Chair?
Please.
Thank you. So in the report, there was discussion about expanding access to wraparound services such as wound care, diabetes education, and harm reduction through enhanced partnerships with initiatives like the Health on Wheels and Harm Reduction Navigator position. I just wanted a little bit more clarity on the harm reduction navigator positions. How many do we have on roster, and how are they deployed, and where are they housed? Thank you.
Dr. Liu or Director?
To the councillor through the chair. Sorry, are you referring to navigators employed through public health services or through the Greater Hamilton Health Network?
Great question. It was referenced in the report. It didn't specify.
Okay, so I think I'll pass that question to Executive Director McCallum.
Yeah, thank you. Through the chair, we've been able through the high priority community initiative and some of our other funding be able to provide harm reduction navigation services to some of our providers. So they work in synergy with organizations like Wesley, like Shelter Health, like HamSmart and Keeping Six, and Good Shepherd. So we've been able to put some investment to expanding harm reduction services and outreach. We work across all of the outreach teams in the city to understand how to better improve harm reduction harm-reduction. We released a report earlier this year that looked at all outreach models and the resource that the city has and potential gaps. So harm reduction is a core tenet of our work. We determined that back in 2020. We will continue to work on that to make sure that we have pathways for people to receive harm reduction supplies or support. Just back to the earlier conversation, we will maintain a commitment to that work.
Thanks for creating that link for the earlier discussion. Thank you.
You're welcome. Thank you. Councillor Clark?
Thank you, and I appreciate the comprehensive report. Can I get an understanding of where Hamilton sits with the provision of mental health services and what the Greater Hamilton Health Network is doing to assist with securing additional funds for mental health services?
Through the chair. So yes, the GIN has a formal mental health and addiction secretariat where we bring together all providers of mental health and addiction services in the city to convene. That group has several working groups underneath it. That's where the harm reduction working group is. We have work underway under schizophrenia and complex illness, and we have work around anxiety and mood disorder. That was also a group that was leveraged through understanding, if we're going to be securing funds for a heart hub, how will we do that together? So we were able to leverage that group. We haven't seen significant investment into this area. This is a huge concern for us. When I speak to an Ontario Health team having both provincial and local priority work, our provincial work has not been focused on mental health and addictions. It's because of our local providers that we have a focus on that work. And we've advocated quite hard that we need the province to focus on it as well. We are suffering and in crisis as a community, and we need to see investment and funding coming. When investment and funding comes, I believe that we are well situated as a secretariat to begin having those really difficult conversations like we did around primary care about, okay, if money is going to come, where are we going to put it first? We're never going to receive enough. But we've been able to make small investments through our initiatives that I talked a little bit about in the presentation to address complex mental health and addictions needs, especially for those who are using drugs and those that are homeless.
So the context to my question is the waiting lists that exist in Hamilton for young people who are wanting assistance with mental health issues. The waiting list can be upwards of 2 years. The waiting list to see psychiatrists, about the same. Trying to get in to see a psychologist, it's a little bit quicker, but still challenging. And I've experienced in my own ward families who were waiting for that mental health assistance. It ended tragically. I don't know how this city and the Greater Hamilton Health Network, what we can do to make it very clear to the province of Ontario that the lack of mental health funding means people on the streets. It means death. We're seeing an increase in suicide, and people are waiting for mental health services and they're not getting it, Chair. And so I guess what I'm asking is, what can we do as a city council, because we don't have that funding, it's not our role. What can we do in working with the Greater Hamilton Health Network to push and advocate very strongly for this additional help? We keep hearing it's coming, it never arrives.
Through the chair, absolutely. I agree with you 100%. Our wait lists are too long, and we see a number of sectors also say that. I am happy to work together to advocate as one collective. Absolutely. I will mention that the ministry has just announced, within the last few months, that they will look at coordinated access, more of a navigation system for mental health to hopefully free up and understand and maximize the resource that is already there. So we are taking part in that project that will be for the whole West region. On top of that, Ontario Structured Psychotherapy is available as a tool to be accessed for more low-level anxiety and lower mood depression. But I wholeheartedly agree with you. We need more attention in this space.
Thank you. I'll speak with Dr. Richardson and try to figure out exactly how we can help, because this is shameful. All of the, and your motion is going to speak to it later, all of some of these changes from the 2000s and back, we made significant changes to the Healthcare Consent Act, the Mental Health Act, but then the funding didn't flow to help any of those patients that are supposed to be in community treatment. So it's a real struggle. I know the healthcare sector is struggling with it, and no one wants to speak up to the Premier, truth to power, because they're afraid of us losing funding. We need some clarity from the province on this. Thank you.
Thank you. I think tragically, I'll first of all recognize Executive Director McCallum, and then I'll just add a comment.
Yeah, I definitely appreciate that. I think this is also about this continuum discussion. We need people to have a medical home as a starting point, because we know that those issues can start to become exacerbated without. So it's all in combination of making sure that our community system is strengthened. So yes, appreciate that.
Thank you, and tragically, but powerfully, perhaps also when we soon receive our population health data, it'll underscore that very crisis, and we could use that in our advocacy efforts. Councillor Tattison.
Thanks for the report. Executive Director McCallum, I saw that one of the goals in the report is implementation of integrated care pathways to support people with multiple or chronic conditions. So I'm going to kind of go in an area that Councillor Nan was touching on. I think I'm going to just take a little deeper dive. So I sit on the ACPD, Accessibility Committee for People with Disabilities. Can you expand on how the work with the GHHN equity-based populations includes people with disabilities? Basically, any specifics of how the GHHN works to support people with disabilities and accessibilities in light of the lack of doctors in our area and access.
Yeah, through the chair. We reviewed and did consultation around disabilities during our first report, so that helped to inform. We know that we need low barrier access for a number of health modalities in our city, absolutely. And that includes a variety of in-person touch points, but also ensuring that we can have virtual and other accessible ways to access healthcare. So that is part of what we work on in the digital space. In terms of our health pathways, our health pathway work is just undergoing. And we are looking at redesigning pathways from a more equitable lens, not just from a health lens. So those with disabilities, those with different languages spoken, those that want, cultural needs addressed are going to start to be built into the pathways at the very beginning. So we're just starting that work.
Okay, thanks. And I respect the fact that disabilities covers many different areas and people. So I respect that. And I guess I just wanted to highlight that I didn't see it highlighted in the report. And I think because we have the IDEA concept and accessibility is, one of our major pillars, that if we could focus on that in the future and bring that forward, that would be appreciated by probably the people that, that I'm talking about. Thank you so much.
Councillor Danko.
Thank you, Chair. Just going back to the presentation, there was one mention that I'm not sure if I must have misunderstood. I believe there was mention of free vending machines that would be giving out drug supplies. Did I understand that correctly?
Through the chair, yes, we've started to initiate a program called Health Boxes These are vending-like style machines for harm reduction supplies. The supply list is still being worked out, but it will include things like naloxone, condoms, items like that to reduce the harms of drug use.
Okay, thank you. So naloxone, condoms, that kind of thing, but they're not going to have needles and crack pipes and that kind of thing.
So Julie Prieto, Director of Epidemiology and Wellness. So through you, Chair, to the Councillor, we will have harm reduction supplies, including clean needles, and yes, kits for inhalation as well.
Councillor.
These are just going to be available in a vending machine, handing out needles and crack pipes.
Director?
Through you, Chair, to the Councillor, yes, they'll be part of the supplies available through the health boxes.
Sorry, Chair, I don't really know what to say to that. Follow-up question would be, is that through city funding?
Through the chair, no, that is through funding that we have secured through the Ministry of Health.
Okay, so that would be something to take up with the ministry then, because when residents get news of there being vending machines in the community with drug supplies, which is the #1 concern that residents have with their parks, finding needles all over the place, finding crack pipes all over the place, and other drug paraphernalia. Residents, where are they getting all this stuff? And now there's going to be free vending machines where anybody can just get whatever they want anytime. Residents are going to have a huge problem with that. So that's something I'll take offline and discuss with staff, and would have to be addressed with the ministry, from my understanding from the answer. Thank you.
Thank you, Councillor. Councillor Jackson.
Good morning. Thank you, Chair Wilson. Just a question. First of all, outstanding presentation, Dr. Liu and Executive Director McCallum. Thank you. Just one question on slide 9. I didn't really hear any emphasis on long-term care providers and, of course, our 2 outstanding municipally owned homes of Wentworth and Macastle Lodges, and just how they fit into the GHH team. And any further elaboration one of you can provide in terms of how this new Greater Hamilton Health Team is going to hopefully even benefit more our long-term care home providers and locations, looking after the frail elderly population of our community. Through you, Chair Wilson, please.
Through the chair, yes, all of our long-term care homes across all of our catchments are part of a GIN long-term care advisory. So we actually have a very strong long-term care group that meets together and understands, concerns. We've launched initiatives lately that looks at reducing emergency transfers from long-term care into acute care. We're working with Hamilton EMS around a new model of care to keep residents at home as long as possible to reduce transfers. And at the same time, we're actually looking at assessing capacity, because what's happened through COVID is that we've actually lost a number of long-term care home beds that will never come online again. So we see decreased capacity in the community, and we need to plan for that with alternative models of care. So we work really strongly with our partners on that.
That's very encouraging and promising to hear, E.D. McCallum, and hopefully with the beds that were lost, don't know all of them that were lost, and of course there were some unsavory conditions, Chair Wilson, as we learned sadly through the pandemic, of long-term care home operators and substandard of care, either operationally or capital building-wise, but hopefully with new beds coming on stream and the promise from Premier Ford with the additional millions of dollars that above wonderful standard of care for additional new beds, and or, as we're going to be going through with Macastle Lodge, additional 20 beds with our $27 million, now $52 million renovation plan. It sounds like it's all on the radar of what the Greater Hamilton Health Team is doing, and I'm very pleased. Thanks, Chair Wilson.
Thank you. Councillor Pauls, please.
Thank you. I just wanted to ask a question about the health boxes that Councillor brought up, Councillor Danko. Are these boxes, do people buy them? Like, do you have to put money in it in order to get the pipes or the needles or the whatever, condoms, or are they free?
Yeah, Executive Director, maybe, could you just walk us through what we know? I think you suggested it's a pilot that's soon to be put on stream, what you know, who's responsible, and the access points. Thank you.
Yes, through the chair. This is a program that was started in Toronto. There are several health boxes already live within the province. It does work like a vending. It's not a paid vending machine, so you're able to access without having to pay. This is in conjunction with a lot of other harm reduction programs that already disperse some of these supplies, but not on a 24/7, schedule. So the supply list is still just actively being confirmed, but no, a person can walk up and identify what supplies they need to use and receive it for free.
Councillor?
I'm just wondering what kind of messaging we're telling our young people that you could try those things, those pipes. I don't understand it. First of all, do we have to do it just because Toronto has done it? Do you think we have to do it? Or what other cities are jumping into this? Or should we take a closer look at where messaging our young people to stay away from drugs? Or are we saying, if you want to try it, go ahead, it's free, take it. Whether we're paying it or not, that's not the issue. The issue is what messaging are we sending to our young people, our young minds
Thank you,
that
Councillor.
are, in this confusing world. What are we sending the message?
I think the question is there a role for the municipality is there permission that is required? Is there the ability to say no with a provincial program? Those sorts of parameters, please, and thank you. If I've got the councillor's question correctly, and she is shaking her head, yes, okay.
To the councillor, through the chair, I think maybe I just start by highlighting that provision of sterile equipment for harm reduction of substance use has been and continues to be a part of the harm reduction programming of within public health services. There's very good evidence to say that the risk of bloodborne infections and other serious infections related to substance use are addressed or mitigated or prevented by the use of sterile equipment. And so that does continue to be an evidence-based intervention for reducing harms related to substance use. And so this does continue to be part of the work of the harm reduction program through the work of public health nurses within the harm reduction program. Maybe I'll just pass to Director Prieto if she can add any other background or context on that work existing in Hamilton prior to what's being discussed.
Thank you, and through you, Chair, to the councillors. So as Dr. Liu indicated, we do provide harm reduction supplies through our harm reduction public health nursing team. I will note, though, that we do receive supplies free of charge from the ministry, and we provide those out to community organizations and agencies as well. So appreciating that there's several different locations in the city where someone could walk in and request clean supplies. And again, noting there through our harm reduction clinics as well as our van needle exchange program.
I think the councillor's question was, so I think you're stating, I could be wrong, that the municipality at present is providing this equipment or these supplies. They're doing it through their community agencies in part. I think the councillor's question had to do with, forgive me, Councillor Pauls, if I have this wrong, was with respect to the unattended boxes, what is the role of the municipality in that? And is there any permissions being sought? Do I have that correct, Councillor
That's
Paul?
perfect, Councillor. I want to know if that's something we have to do or is something that we have a choice on doing
Okay, thank you.
as a city. I just don't understand it. I'm sorry.
Yeah, they're just
Messaging.
conversing. Yeah, sorry to cut you off, Councillor. They're just conversing and understanding it's a pilot. We may not know the answers, but Director.
And did we agree on this pilot, the councillors?
So through you, Chair, to the councillors. So as Melissa had indicated, this is being rolled out in Toronto, and so we are piloting here. So Public Health is certainly working alongside GIN, particularly to determine what supplies make the most sense to be part of these health boxes. I will note that it has not been brought to council for permission to have these health boxes in the community. We do see this as sort of a low barrier option for individuals who really need access to clean supplies, noting that, of course, it might be challenging for some individuals to find supplies in a community organization. So this is about, low barrier access. We always, with harm reduction supplies, certainly make note of the importance of clean disposal, for example, noting as well things like not sharing. So again, it is a harm reduction initiative to reduce the harms associated with opioid use or with other substance or drug use. And as Dr. Liu alluded to, it is an evidence-based practice that really is both supportive for individuals who are using substances and individuals in the community as well.
I understand all that, but I do not understand. I want to be able to vote against it. I want to be able to bring it to council. And it's not that I don't want to help. It's just I don't understand why we are impressionable mind, young people saying, okay, here it is. If you need it, take it. I don't understand that. And, I just wanted to come before council before we do a pilot project like that. I was wondering one more question. How many other cities are doing it? And sometimes we say that city has done it, so we have to do it. We have to really look at the consequences of this. So is there any other cities that have done
what
this?
other jurisdictions, municipal jurisdictions are providing the vending boxes or help boxes?
Thank you, Councillor Wilson.
To the Executive Director.
Through the chair, I know of at least 3. Ottawa, Toronto, and Brantford just launched their box in the spring.
Thank you.
So 3 out of 44 cities are trying this pilot, right?
Through the chair, I don't know the confirmed number. Those are the ones that I just know off the top of my head.
Thank you, Executive Director. Okay.
Thank you. Thank you for that. I just want to be able to council to bring it up so that we can vote whether this pilot, we should go forward. We do have safe injection, and we've been doing that. Now we're adding one more layer of where people can get help. I'm just concerned about the people that, inquisitive minds, young people out there. So that's all I'm concerned. And, and I want everybody to know that I do care about people that are in this predicament, but we need to have more places where they can get help.
Thank you, Councillor.
Thank you.
Councillor Cretch, please.
I think Dr. Liu answered my question, and then I believe others followed, but I think it's important to really state it as plainly as possible. Can someone confirm for how long we've been providing these supplies in the community and how widely we've been doing so? Because there seems to be some confusion here. As someone who's spent a lot of time volunteering in organizations across our city, I'm very well aware of the practice we have here. This is not new. This is not news. And can someone speak a little bit more clearly to the sort of reasons why we want to make sure this is more low barrier, what the barriers that currently exist to getting these supplies are, if that's clear? Those are 2 questions, really.
So are the 2 questions understood? I think the first question is how long have we been in the practice of working in partnership with community agencies for the dispensement?
Yep.
And the second question being what is the rationale behind? Dr. Liu.
To the councillor through the chair, work in the harm reduction program, including use of cleaner, sterile equipment, goes back well before my time in public health, on the spectrum of years into decades. And engagement with community services has been an important component of ensuring that folks who are accessing services through other means may be able to access necessary services in a time, place, or from a person that is appropriate to them.
Right, and I think what I've known, just as myself, in spaces like this, is that we're trying over time to reduce the barriers, right? So for a long time, and decades ago, it was a lot harder to get access to clean supplies, and this increased mortality, increased people dying as a result. And so by reducing the barriers here, we're not only making this safer for people, but reducing harm and reducing death. Can you speak to that and how this is a progression along that decades-long advocacy around trying to reduce barriers for people to be able to access safe equipment?
To the councillor through the chair, so harms related to the use of non-sterile drug use equipment can be very, very serious and lifelong, but also acute. It can include bloodborne infections, including HIV or hepatitis C, for example, can include skin and soft tissue infections or serious bacterial infections, including infections of the heart, described as infective endocarditis. These are very serious infections that carry with them a significant morbidity and mortality risk. They are significant health harms, and the use of sterile equipment for the purpose of drug use does significantly decrease the risk of any of those infections occurring. And so we know that the burden or risk on an individual basis of those infections occurring has decreased when somebody has access to sterile or clean equipment for the purposes of substance use. And so ensuring that those who are at the highest risk of those things occurring is certainly an important part of addressing health inequities that may be related to those particular infections, for example.
Thanks, that was really clear. I just have a comment briefly, just to say that, if people want to start having these kinds of evidence-based discussions politicized here, I think it's a really dangerous and slippery slope. What we're hearing from our medical professionals is quite clearly that having safe supplies for people who are going to use drugs regardless. Let's be really clear and say that again for those who don't seem to understand this point. For thousands of years, people have been using drugs. People are going to continue to use drugs. The evidence is pretty clear about that. If we provide safer supplies for people and safer places for people to use drugs, it'll be better health outcomes for them, and fewer of our neighbors will die. Fewer of our neighbors will die. So I really want to make that point here today to say that that's what the evidence says, that's why we're doing this, and that's who we're helping. And so I caution people trying to politicize that.
Councillor, respectfully, I think people can express their concern through questions, and they can perhaps not agree with a direction, but I think to label it as politicization is perhaps not appropriate in this case. I'm going to ask Councillor Tattison to take the chair, please.
Go ahead, Councillor.
So, thank you. Through the acting chair, what I'm still not clear on, if I could, Councillor Paul's question, I'm still not clear. I understand that public health, in partnership with community agencies, has been providing safe apparatus through community agencies. What I'm still not clear on the pilot of the vending boxes or help boxes, is or is there not a supposed role for the Board of Health in this regard, in the dispensement of approval? Do we have any regulatory role in that regard? Thank you.
to the councillor through the chair. And so the Ontario Public Health Standards do include harm reduction programming, including the provision of sterile supplies or access to sterile supplies as an element within the standards. And that's the scope and purview through which this work has continued and existed. The work to engage with community partners around harm reduction programming is something that the program does engage with directly over time and is continually reassessed over time as well.
So thank you through the chair. Just so I'm clear, will there be a report coming forward at any point to seek any kind of permission from the board in this regard? I think that's Councillor Paul's question.
Through you, Chair, to the councillor, no, there will not be a report being brought forward for permission around the health boxes.
So no report, no permission sought is necessary, is what I'm hearing. Okay, thank you. My second question through the chair is, if understanding the very thorough answer on explaining low barrier and existing practice, I'm wondering if someone could comment from the bench perhaps on the tension, and that's my word, of I thought I heard earlier in the morning the value of safe consumption sites and harm reduction is that the opportunity perhaps at any given point on a person's journey that they're not alone and that it may be that one chance where they get to talk to a professional about seeking another path, seeking not to practice, and how that collides with or complements or not with a vending box where there isn't a person there to have that perhaps timely discussion. I'm wondering if someone could comment on that scenario through the chair.
Through you, Chair, to the councillor, thank you for the question and certainly appreciate, what you're noting between the notion of wraparound and where individuals are in their journey and health boxes. So again, as Dr. Liu indicated earlier, there's a spectrum or there's, multiple harm reduction strategies that are necessary to really assist individuals that are using substances to reduce both harm and death. We also know that, individuals are at different points in their journey, and sometimes it's not at the point where they're looking for that additional support around wraparound services. It's really about staying safe in the moment and needing access to safe supplies in that moment. And so, again, appreciating that harm reduction strategies, there's multiple that need to be implemented, some of which are having conversations with individuals when they're ready around what treatment might look like. But sometimes it is about just providing low barrier access to supplies to keep an individual safe in the moment when they're going to use a substance.
Thank you very much. I appreciate that. Sorry, I will assume the chair. Thank you, Councillor Taddison. Any further questions? Councillor Clark, followed by Councillor Pauls.
Thank you, Chair. I just want to understand what we've heard this morning. I believe public health is using the authority of the Chief Medical Officer Health in determining and working with the province in terms of where these health boxes can be placed or how we implement them. In essence, it's delegated authority to staff. Can I get confirmation on that?
Dr. Liu, please.
To the councillor through the chair, so the work of the program to engage with partners around the way that they would provide access to harm reduction supplies is one element of the delivery of the requirements under the Ontario Public Health Standards in terms of harm reduction. I don't know that I would describe it specifically as a delegated authority, but it's the standards and the harm reduction standards do include that provision, and we operationalize that both through provision of the supplies directly by our staff, for example, in settings where the harm reduction program works, as well as through community agencies who deliver the services directly themselves.
So staff made the decision?
Yes.
Thank you for that. Can I ask, in our harm reduction programs that are currently operational, at least I still think they're operational, do we have an age of majority requirement for clients coming in?
To the councillor through the chair, there is no specific age of majority, but as so no, there's no specific age requirement.
So a young person, 15 years of age, could come in with the drugs in hand, and we would assist them in the administering of those drugs.
To the councillor through the chair, assistance with administration of substances is not part of the core work.
We provide the materials that they need to inject it. We stand there while they heat it up and put it in their veins. Is that not correct?
We do provide sterile equipment. I'm not personally aware that our harm reduction nurses would personally observe the consumption of substances on site.
So we give a needle to someone that we don't know, and they walk away and inject themselves elsewhere, because that's not what I heard this morning.
To the councillor through the chair, so we are not the operator of any supervised consumption sites. There have been sites operated by other organizations where substances can be consumed on site as permitted under exemptions under the CTS framework or through the Controlled Drugs and Substances Act. But the provision of sterile equipment for the purposes of harm reduction or substance use does not relate to the permitted consumption of substances or the observation of substances being consumed.
So we're providing clean equipment. We don't verify that they're not under the age of 16. I have family that are 12 years old and they look much older than that. They could walk in, get a clean needle, and use a drug for the first time. There's no one watching over them, no one verifying their age. We just enable it.
Dr. Liu.
To the councillor through the chair, I don't believe that we would necessarily refuse an individual attending to access our services.
So one last question, if I may.
Yep.
And it may be rhetorical. I don't mean it to be that. I mean it to be clinical. At what point is the provision of the harm reduction services to folks in our community who are presumably addicted, at what point does it become enabling to that clientele, to the general public, to people who want to try a drug for the first time? At what point is it enabling?
To the councillor through the chair, I am not aware of any evidence to support the fact that the availability of sterile harm reduction supplies increases an individual's risk to initiate substance use.
And I'm not aware of any study in Ontario that has looked into it, but when the British Columbia enabled the use of drugs, it exploded with the number of addictions that they have in that community. So we have to be cautious. At some point, you have to make sure that we are not enabling young people to try drugs. And at the moment, it doesn't appear as though we have any accountability framework to prevent young people from coming in, getting the syringe and trying drugs. Just making the point. Thank you.
Councillor Pauls, you're on next for questions. Questions, please.
Thank you, and I thank Councillor Clark, exactly what I was going to say, but I just want to ask one question. We're not monitoring this, right? So it's out there. What makes a person just get all of them and sell them? Sell the condoms, sell the needles, whatever is there. If we're not monitoring them, what help is it to these people? Anybody could get them, right? So I want to be able to vote no on this matter. And you're saying we're doing a pilot project without our consent, and I'm against that because I agree everything that Councillor Clark said, Councillor Danko, we're enabling.
Councillor Pauls, respectfully, I think a number of us around the table have tried in our questions to bring some clarity about the role of the municipality. Tried to do that respectfully with one another. And I think what we've heard is there is nothing coming forward for you to vote on. That doesn't mean at the point of commentary you can offer your opinion on this in terms of the government of Ontario and the pilot. But right now, if you wanted to proceed with your question, which is, is there any monitoring in place that the material that is being dispensed cannot then be sold? Is that your question?
Okay. Councillor Wilson, thank you for that. That's what I want to ask. What makes it, do we monitor it? That's all I want to know.
Okay, thank you.
To the councillor through the chair, I think I would defer this question to Executive Director McCallum, as the Greater Hamilton Health Network is directly involved in the operation of the service.
Through the chair, there is no monitoring of what a person would do with the supplies post receiving them.
Thank you for the clarification.
Thank you for that. So we know clearly we should not be doing this if there's no monitoring. I have 9 grandchildren. What message am I sending to them? So I just want to be sure the public knows I'm totally against this. Totally. Thank you.
Thank you. Are there any further questions to staff and to our guests? Okay. I know this is a challenging topic on many fronts, and I appreciate that we keep it to questions and be respectful that we may not all share the same opinion and that staff are here to help answer. Seeing no further questions, if I could have Councillor McMeekin and Councillor Wang receive the presentation, and we'll vote on that, and then we'll have the same mover and seconder for the receipt of the report. Councillor Jackson has a thumb up along with Councillor McMeekin.
Councillor Pauls, we're just waiting for your vote.
Thumb up from Councillor Pauls. Thank you. That carries 13-0. The same mover and seconder on the report. It's on the floor. Are there any questions on the report? I've allowed some latitude and fluidity between the two. I see none. On the report, please. Oh, beg your pardon. Beg your pardon, Councillor Clark. Councillor Clark, please, on the report.
So more for the public consumption. This report does not have any recommendations, so it's not a report that is recommending to public health that we implement these boxes. It is, as I read the report, an information report on everything that the great Hamilton Health Network is doing and about to do and hopes to do. That's basically what this report says. Buried in that report is the discussion about these boxes, which, as I believe it was Dr. Liu indicated to us, this board did not direct it. The standard is from the province of Ontario, and they direct it. Do I have that last part clear? I think I do.
Dr. Liu, is that an accurate summary?
To the Councillor through the chair, I think so.
Okay. And so if you don't agree with that, there's really no place to vote against a proposal. You can vote against receiving the information of the report, which is more of a political statement, but it has no validity in stopping what is happening.
And to the Councillor through the chair, yes, this is an information report.
Thank you. Just wanted to make that clear.
Yep, thank you. Any further, Councillor Pauls, please?
Thank you. I just want to ask, if the province directs something, do we have to adopt it? It wasn't, because if it was directed, then we would have to adopt these health boxes. But so I want to vote against that.
Yeah. So
can I do that separately?
Yeah. I think respectfully, Councillor Clark just articulated the decision, which is ours, which is there is none, in that permission is not being sought, and their permission does not have to be granted or withheld. However, it is always the prerogative of a member of this committee or any other committee. If you wish to make a statement, you feel strongly about it, you can vote against the receipt of the report, but that's the report in its entirety. And I think that's also what Councillor Clark was saying. This is one aspect within a larger report, which is setting out the activity and the work and the future work of the network. But again, that choice will be yours. But just to clarify, permission is not being sought, so permission cannot be granted or withheld, okay?
Councillor, I understand that. I just want to make it clear, just because the province says they're doing this, we don't have to adopt it. That's all I know. We don't want people to say we have to do this. Am I clear?
I think if I've understood the counsel that has been offered from the front bench is this is a directive and a piloting practice that is being exercised under the authority and the direction of the Ministry of Health. Okay, so if you'd like to vote against the receipt of the report, again, the prerogative is yours, but there is no rule at present for the municipal jurisdiction nor that of the Public Health Committee, okay?
I appreciate that, but
okay.
All right, I'll vote.
Okay, thank you. Any further commentators or questions? Seeing none, we have a mover and a seconder on the report.
Thank you, Councillor Nan. Councillor Nan, can you, sorry, Councillor Pauls, thank you. Let me just.
Thank you. That carries 12-1. We're on the topic of motions. I have one up first, and I'm going to turn the chair over to my colleague, Councillor Taddison, so I can introduce it.
Introduce your motion.
Thank you. It is moved by myself and seconded by Councillor Clark. Would you second? Thank you. It is moved by myself and seconded by Councillor Wang. This is a historic overview of the relevant mental health policy and its implications for the City of Hamilton. A, that staff be requested to report back to the Public Health Committee by Q4 of this year with an overview of relevant mental health institutions, policy and implications for the city and its efforts to address the declared homelessness, mental health, and substance use crises. Specifically, one, an account of those institutions in Hamilton working with the city and in what capacity to respond to this intersection of homelessness and mental health. 2, a historic overview of the deinstitutionalization process in Ontario and any specific impacts on Hamilton. 3, the Mental Health Act of Ontario, and 4, the roles and responsibilities and purview of authorities as set out in the Mental Health Act of Ontario. Thank you. I'll assume the chair.
Chair assumed.
So, sorry, the chair would stay with Councillor Taddison for the motion, but we do have a speakers list of Councillor Jackson, followed by Councillor Clark, followed by Councillor Danko.
It's okay, Councillor Jackson first.
Thank you, Acting Chair Taddison. And I truly want to thank Chair Councillor Maureen Wilson for this motion. Now, I'm not being a little glib or cheeky because we haven't conversed in advance of this motion here that's been tabled publicly by Councillor Wilson. And I'm not sure if her reasoning and my reasoning are going to be the same, but right now I am on the same page with her, and I want to applaud her and thank her so much for, again, I'm not sure we're coming at it from the same pathway and reasoning, but definitely the wording in this is exactly where the overwhelming sentiment of my community, Acting Chair Taddison, has been, especially over the last 13 months, with the unsavory, unhappy, oftentimes situation with the encampment protocol. And I began mentioning about reintroducing the institutional aspect for many in our community, Acting Chair Taddison. And I'm going to repeat myself from 3 months ago when I first raised this point, and one or two of my colleagues cautioned me publicly about the reintroducing institutional topic into the conversation. But I can tell you the number of times, Acting Chair Taddison, I heard from my constituents at 2 or 3 locations in my ward specifically about 10 people that had mental health issues, that had narcotic addiction issues, and citizens abutting these areas would literally be pleading with me, Councillor Jackson, why don't we have a proper structured environment where these individuals so desperately, for their sake first and foremost, need 24/7 wraparound care in a structured environment, i.e. institution, where they can be looked after as long as they need to be to finally, hopefully, get their lives back on track, free of their mental addiction, free of their narcotics addiction, if at all possible. A constituent of mine did a lot of homework for me and told me back in 2000, the Harris government of the day actually closed institutions. Like many of my constituents pointed to, Acting Chair Taddison, the Hamilton Psychiatric Hospital at West 5th and Fennell that was in existence for the longest time, that in 2000, if the accuracy of my information provided by this constituent that did a lot of great homework for me, because I didn't have the time to, said the Harris government closed at that time. And so many of the individuals we now see homeless and that have these issues that are serious issues to them are now in our communities without proper supports. And what happens is a paramedic, a police officer, a social worker shows up when I get a complaint about an individual screaming, yelling, threatening, intimidating, a senior walking by a park. And the paramedic shows up, the social worker shows up, calms the individual down, maybe takes them away for 24 hours to a hospital, and in a day or 2 or 3, the hospital system, this is all documented, releases the individual. The individual goes right back to the same location, and we start the maddening circle and cycle all over again. So the parts of this talking about, let's do a historic view of how the deinstitutionalization process happened in Ontario, an account of those institutions that are working in the city. I just say this conversation is so timely and necessary. And I know my community wants overwhelmingly people who need help so seriously and desperately on the margins of our society. Let's, Tom, get them into a structured environment where they can get it. And yes, conversely and consequently, make our neighborhoods safer and free of fear of having to walk by individuals that have these serious matters that they should hopefully, God's willing, ultimately get help for. So I'm fully support. If nothing else, this will open up the conversations very timely. Thank you, Acting Chair Taddison.
Thank you, Councillor Jackson. We're going to move over to Councillor Clark.
Thank you, Chair. I'm going to support the motion. I'm going to ask for a couple of amendments, but we need to be clear that the Mental Health Act review in 2000, which made significant policy changes within that document, enabled psychiatric facilities like St. Joseph's, which replaced the previous psychiatric hospital, to release patients to the community if they have been determined by the psychiatrists on staff that they are able to function in the community. If you look at the Mental Health Act, Section 33 of the Act, and that Act, I was the parliamentary assistant to the Minister of Health at the time, so I helped draft this Act with the assistance of the Liberals, with the assistance of the NDP. It was the first legislation brought through the House in that time frame that was all parties involved. We clarified in that Act the role of the police. In the past, the police had to witness the violence to determine that someone could hurt themselves or hurt others. Now they can make a determination on reasonable grounds. The Act releases people, enables the psychiatrist to release people into the general public with a community treatment order. Community treatment order would indicate that, yes, I'm agreeing to release you into the community, but your obligations in this order is to go to this facility on a weekly basis, whatever the case is, go here for verification that you're taking your drugs, whatever the case is, go live here in supportive housing. The problem, Chair, is that there hasn't been any funding for it. Ted was there, I was there. We had this big hoopla, we all got this approved with all parties supporting it. But the intention was millions and millions of dollars would flow to community treatment orders, would flow to psychiatric supports and assistance, and it didn't happen. So people have been released, there's no follow-up, they're on the streets. Maybe they were completely of sound mind, and schizophrenics can be. They can go from completely lucid to something that's not so lucid. But they were released to the community with the hope that there would be supports, and to my mind, I've never found the supports, Chair. I've been looking, I haven't found it. And so our staff get yelled at, counselors get yelled at, but it's the province that is neglecting to put the catcher's mitt in, and I'm sorry for but that's what it is. If you're being released into the community, we're going to wrap around you. We're going to help you. We're going to make sure that you get your life back in order and you can have normal function with your family and your loved ones. It's not happening. So this report, hopefully, will demonstrate some of the problems that we have. But if the suggestion is that we're going to have the police go out and pick people up on the street who are demonstrating that they're mentally unwell and arrest them and incarcerate them and put them in an institution, That is not consistent with current Ontario law. Read the Act, understand the Act, because it's important with the crisis that we have. In closing, Chair, I would like to ask that in item AI, where it says an account of those mental health institutions, I'd like to add right at that point, hopefully with a friendly amendment, an account of those mental health, addiction, and rehab institutions in Hamilton. We need to understand who's doing what in our municipality. I've still not received an answer, Chair, as to how many rehab beds we have in Hamilton. I don't think we have enough. But if you could include that in there, Chair, and if it's not willing to be a friendly amendment, then I'll move it as a regular amendment and see if I can get the support of this committee. But we're not simply dealing with mental health, we're dealing with addiction, we're dealing with that combination, and it is very challenging. And we need to get reports back on who's doing what in the community. So I look to you, Chair, are you willing to accept that as a friendly amendment? The insertion of after mental health, addiction, and rehab institutions in Hamilton.
Councillor Wilson, do you accept that as friendly? Or do you have further comments or questions from staff or from the bench?
I mean, I guess I don't know enough about it. In my mind, the building block of our understanding has to begin with mental health. And that's why the focus was on mental health and non-addiction. And that's why the focus is on the Mental Health Act of Ontario. And from there, we can have perhaps other conversations. I don't deem it as friendly.
Thank you. I will consider that, and at the appropriate time, perhaps move the motion.
Okay, thank you, Councillor Clark. And we'll go to Councillor Danko right now for his comments and questions.
Thank you. Really appreciate this coming forward. Very much supported. I think it is important for us as a city council, as a municipal council, to get clarity what our roles and responsibilities are versus those of the provincial government, especially as the St. Joseph's West 5th campus is continuously raised by residents across the city, a facility that is located in Ward 8. As far as I'm concerned, mental health is healthcare, and healthcare is 100% the responsibility of the provincial government. So I would very much appreciate getting clear clarity on that, just to make sure that residents understand that differentiation. I think Councillor Jackson and Councillor Clark really said it all. My one question on this is a trend that I've just recently become aware of long-term care facilities sort of taking on some of the burden of mental health treatment that would have otherwise been addressed in other institutional facilities because there's nowhere else. So is staff able to take that into consideration in the scope of the direction before us as well? The use of long-term care facilities as mental health treatment institutions.
Doctor?
To the councillor through the chair, that's not an area that I necessarily have any specific knowledge to at this point, but certainly it could be part of the information collected per committee direction, should that be the decision.
Thank you. I'll spell that out directly with staff, presumably once this direction is passed. Thank you.
Councillor McMeekin is next on the speakers list.
Councillor McMeekin is next.
Thanks, Chair. Isn't it ironic, something that set out to be something good? It was a deinstitutionalization. Wolfensberger, who was the academic guru, and his colleagues actually referred to the process as, remember, Brad, normalization. sad problem was successive governments didn't normalize things. And here we are. So I support the motion. You know, I'm almost tempted to say that, well, no one's guilty, we're all responsible. And the sooner we get at it in a structured, helpful way, with the kind of focus that you have set out for us, Councillor Wilson, if it's taken seriously, it will prove helpful. Thanks.
Thank you, Councillor McBeacon. No more speakers? Okay.
No.
So I think we'll go back to Councillor Clark, who wants to add an amendment to item A1.
Yes, that I would move an amendment to A1, that after the words mental health, we would insert, comma, addiction, comma, and rehab institutions in Hamilton. I'm looking for a seconder for that. Councillor Tom Jackson has seconded it. While I heard the chair very clearly indicate that she's trying to get an assessment and accounting, if you will, of mental health services in this community, there are many institutions that have deemed addiction to be a mental health issue. And unfortunately, we can't talk about one without the other because the two feed into it. Let me give you an example. We have people who are no longer in a hospital or no longer in supportive care, and they're supposed to take meds because they're diagnosed as a schizophrenic. The meds make them feel funny. They don't like it. Since there's no one there to support them, they stop taking it. And what do they take to get rid of the voices? Black market drugs. And that's happening right across our community. And so addiction, whether or not we wish to address it as such, and rehab, all forms a part of one's health care. And you can't really talk about one without the other. If you want to get off of the drugs that you're taking and you go and talk to your family physician, they will diagnose you a different medication that will help you get off of the medication. And they have counselors normally in the family health doctors' offices that can assist them. It's all part of one healthcare practice. So I encourage my colleagues to think of that when they're making the vote on this minor amendment to this document. Thank you.
I'm just going to ask, I'm thinking that what Councillor Clark is looking for is a wider swath of the agencies that are all involved with this crisis that we're dealing with. Councillor Wilson?
Thank you. I don't want to be difficult about this, but I think there is a clear, I just would like to express caution. I think addiction or falling into a path of over-the-counter, unsubscribed, is perhaps a consequence of deinstitutionalization gone unfunded, gone with an absence of infrastructure and complement. But I think it's, for me, when I wrote the motion, the base is that of, we have a mental health crisis. How did we get here? What was the intent? Was the legislation to oversee that intent? Who's involved? And how's it working? In my opinion, I don't see addiction as a core tenet of that discovery. It may be an outfall, an outcome, an unforeseen consequence, but I don't see that as the same. I think there could be another complementary motion, but I do think addiction may inform or be a consequence of. I don't think it's the root of when I wrote this motion. Thank you.
As the acting chair right now, is it out of order if I ask for the opinion from the bench? Clerk? The difference between encompassing what Councillor Clark wants and just leaving it as mental health institutions. Okay, can we have some comments?
To the committee through the chair, I think having had the opportunity to provide a bit of review and input to understand the intention of this motion, I understood it to relate primarily to that history and path around institutionalized or deinstitutionalization, which I believe the concerned facilities as described in the motion is scoped in a way that would encompass that and allow staff to prepare a report that would describe that. I'm not aware of a specific distinction between the other types of facilities as outlined that would necessarily provide a significantly different perspective on that history or path of deinstitutionalization. But an expanded scope of the motion may impact the timeline or resources around preparing the report in a timely manner. But the sort of narrowed scope of what has been proposed in the motion as presented is something that we would feel is feasible in the timeline outlined.
So then there's going to be long-term considerations that are going to be involved here if we accept Councillor Clark's amendments, correct?
If the chair wishes to debate this and provide comments, you should hand over the chair to someone else.
Councillor Wang, take the chair, please. Can you answer that question? Is just there going to be time considerations if we include all those agencies and so forth that we saw on Drug Overdose Awareness Day in August that you were there? Is that going to be, I think I understand Councillor Clark's idea here. Is that something that is incorporated without so mentioning it?
Yes, to the councillor through the chair. Yes.
Okay, thank you. No more questions? Any other comments? Councillor Clark.
I'm not sure I really understood that last exchange. So what will you be looking at based on the motion as it is unamended?
To the councillor through the chair, I would understand this direction as relating to a background on the relevant legislation concerning mental health, likely primarily the Mental Health Act, those facilities where individuals may have been admitted voluntarily or involuntarily for the provision of mental health care, and the background and context of deinstitutionalization or the closure of facilities and the move towards a community treatment focused approach, and how that relates to the current context and relevant legislation and healthcare services.
And do you see any correlation between increased drug use and the fact that residents who are seeking mental health services have a 2-year list or a 1.5 year list? Do you see any correlation to the increase in drug use as a direct result of failing mental health policies?
To the councillor through the chair, I don't know that I could suppose prior to staff having the opportunity to dig into the issue further and prepare the report, we know
That's what I asked for, and you just said no earlier to it.
So I think related to particularly addictions and rehab facilities, for example, I don't know that relates specifically to the intention of elucidating the history and process of deinstitutionalization as the author intended. I may have to defer to the motion author on that piece. The feedback I would provide is I believe that these issues are intertwined, and as the motion is presented, I believe the report to be brought forward would be able to meet that intention.
Yeah, the challenge, I guess, for me is knowing too much of the Act. So Section 33(1) of the Act deals specifically with community treatment orders. And so if a patient is coming out of a psychiatric care, they need to go and follow this community treatment order. And a part of that will be, in some cases, direction to drug counseling, addiction counseling. That's all part of it. I don't know how we can separate it out and say, yeah, we're going to talk about mental health, not the ramifications of a failing mental health system, which is causing people to take on way more drugs in our community than was there before.
Point of order, please.
Carry on.
The motion is mine. The
We're
medical
not debating your motion. Point of order. We're debating my amendment.
Yes, I understand. But I think you're inserting Dr. Liu into, he's given his answer. I'm the mover of the motion. I didn't deem it as a friendly. Your amendment is on the table, and you can argue it as such. I think that what is occurring right now is wanting to pull the associate in a direction where he's already given his answer. It's most uncomfortable.
It is most uncomfortable, and it's highly unusual, but Councillor Taddison, in the chair, while acting as the chair, directed a response from Dr. Liu. I didn't do that. The chair did that. Now you're saying I can't ask questions about that.
Carry on, Councillor Clark.
I'm trying to understand why we are separating this out. I know the mover wants to talk about mental health, but mental health and addiction are intertwined. On the street, in the homes in my ward, everywhere in the city of Hamilton. And yet we're excluding it completely. So please help me understand the rationale for your answer to the question from Dr. Taddison, from Councillor Taddison.
Master.
What's the issue here?
To the councillor through the chair, my comment related more so to the fact the issues are certainly intertwined, and I believe that the intersection of the issues of mental health and addiction is likely to come out in the report once staff have the opportunity to prepare it. What I perhaps misspoke or was not sufficiently clear is that including a detailed account of all, for example, addictions and rehab facilities may necessitate a bit of additional time or result in a lengthier report than for example, what is put forward in the motion as Q4 2024. While not necessarily exiting the spirit of what is intended to be achieved through the motion. But I would perhaps leave that to the hands of the individual crafting the motion.
And I guess the challenge that I have is we have admitted that they are intrinsically intertwined. They are one. And by implication alone, you've indicated now that it will likely end up being in the report because they are intrinsically intertwined. And I'm just asking, why not say that up front, that they are? The mental health challenge that we're having in the city, The emergency and the addiction emergency, both of them are intertwined. I'm simply asking that we get a report back on that. What are those services being offered? And what rehab beds are in the city? That's all.
Thank you, Councillor Clark. Councillor Wilson, I think I'm going to go to the vote if you don't have anything further to say, or is there some people? Oh, Councillor McBeacon.
I'm again, I'll repeat, appreciative of the motion. And it is a good start of what I would hope would be a fruitful, honest, and more than just an academic discussion. That having been said, I want to speak to the amendment. I think the mover of the motion, I should suggest this respectfully, is actually open the door to the amendment with the reference to addressing declared homelessness, mental health, and substance abuse is right in the motion, is there. And looking for comments about how mental health is relevant in the context of homelessness, mental health, and substance abuse. I think that was, unless I'm missing something, I think that was the councillor's point. And I think as I read the motion, and I agree with everything in the motion, and I don't disagree, given that the mover of the motion has actually opened it up herself to including the words in the amendment. And I say that respectfully, because you're both my heroes.
Thank you, Councillor McMeekin. Any more speakers on the list? I don't have access to it. Okay, let's go to the vote on the amendment.
Sorry, Councillor Tadison, I'll just need you to input your vote again. Or you can show me visually if it's not loading. Thank you.
And it passes at a vote of 7-6. Chair, is back to you.
We'll vote on the motion as amended.
Oh, sorry. That's as the motion as amended?
On the amended motion, please.
And we go to the amended motion now for the vote.
I have a question.
Councillor Wilson.
Respecting the comments of our Associate Medical Officer of Health and the time, I'm not willing to set staff up for a task that they've already told us publicly is not within their grasp. So I would respectfully move the report back or forward, if you will, to, I will ask Dr. Liu, would Q2 2025 be appropriate?
To the councillor through the chair, yes, that seems like it would be feasible.
That's my amendment.
So that's another amendment to this motion. Let's ask, seconded by Councillor Jackson, that we move it back to another quarter.
This could be a friendly amendment because it's being made by the mover.
All right.
So as long as the seconder is also in agreement.
Sorry, learning as we still go 2 years in, and we'll vote on this motion. The amended, sorry, we'll vote on the motion as amended. Thank you.
Councillor Nam, we're just waiting on your vote. Thank you. That carries 13-0.
Oh, yeah, sorry.
Chair, it's back to you.
Thank you, Councillor Taddison. We're on to the second motion, 11.2, analysis of Hamilton schools with adequate HVAC systems. Councillor Nan, please introduce your motion along with your seconder.
Thank you. It's moved by myself and seconded by, I think, Councillor Huang initially.
Yes.
Yep, thank you. And so my colleagues will remember that this was a notice of motion in the previous meeting, and it remains the same. So whereas Hamilton experienced extended heat warnings that lasted 6 days during the school year last term, and whereas to date Hamilton has experienced 3 heat warnings and/or extended heat warning events totaling 8 days during the 2024 secondary school summer season, and whereas anecdotally, several classrooms across the city of Hamilton failed to have adequate heating, ventilation, and air conditioning systems during the heat waves, and whereas anecdotally many children suffered heat exhaustion and other heat-related illnesses that also prevented their attendance at school, therefore be it resolved that the public health staff be directed to work with local school boards to determine their capacity to provide Hamilton schools with adequate heating, ventilation, air conditioning, HVAC systems to address air quality and room temperature concerns. Chair, I think the motion does speak for itself. I've heard from many Ward 3 parents as well as parents from other schools around the city where the schools are not brand new, where the schools are suffering aging infrastructure. And we have a school board that is inadequately funded to make capital repairs that are necessary. And then the need to hone in on those capital repairs that directly impact the health and well-being of our children who are attending those schools. So I think the rest of the motion is self-explanatory and hoping for support. Thank you.
Thank you. We have 4 speakers, Councillor Danko, Clark, Beattie, McMeekin. Councillor Danko.
Thank you. My apologies, Chair. I suppose I should declare a non-disqualifying interest on this item. I do not have a pecuniary interest, but my wife is currently the Ward 7 Public School Trustee. Thank you.
Thank you for that. Councillor Clark.
Thank you, Chair. I have concerns, and I'll put them up front, and then I'd like to hear from Councillor Nan. The way I'm reading this is the City of Hamilton, through public health staff, are inserting ourselves into school board business directly, specifically their capital business. Can I get Councillor Nan to...
Through the chair, sure, happy to respond. And the motion direction was clarified in terms of making sure it was within scope with Dr. Richardson directly. And the goal is not to have City Council or Public Health step into the role of the school board, but instead from the perspective of having adequate data for us to understand what might be contributing to the health conditions that our children are experiencing in the city of Hamilton. This data would be beneficial for public health as well.
So I'm curious why Dr. Richardson wouldn't have brought this forward as a report and recommendation from staff. She has that authority as Chief Medical Officer of Health.
I can't answer that question, Chair.
But you did speak to her and you verified that she supports this, correct?
And that is correct. Through you, Chair, it was in response to a previous report from Public Health Committee related to heat and related illnesses. And it was through a course of conversation with staff during that committee meeting that I indicated on the floor that I'd like to follow up with the doctor directly to put together language that would be appropriate to satisfy the questions that I had asked, and this was the proposed language.
Thank you.
And may I ask, have we reached out to the actually 3 or 4 school boards in our jurisdiction to see where they stand on our interventions? Because they are struggling with the capital cost of doing all of this without funding, and they're the ones that have to go to the province. So I'm trying to understand how we insert ourselves.
I'm not sure the permission of the motion has been sought yet. So Dr. Liu, did you wish to add any information?
To the councillor through the chair, we have a very positive working relationship with our school board partners, and I think with direction that we would be able to work with them to bring forward some of the information that is of interest here.
Thank you. Councillor?
Thank you. But what prevents the school board from bringing forward that information to the staff doing the work and bringing it forward to the board and saying, here's the proof, we need these air conditioners? That's usually the process. Anyways, I guess I'm being a little bit rhetorical. My apologies, Dr. Liu. I have troubles with the motion. I understand the intent of the motion. I get it completely. But how would we feel if the school board stuck their nose into how many recreation centers we have across the city, or how many splash pads we have, or how many pools we have, or how we're conducting our cooling centers? That's in essence what's happening here, and it may not be well received by the school board, and I'm not sure we should be doing it. If they come up with a process and ask us to get involved, absolutely, then I think I'd be on side with it, but that's not happening here. Thank you.
Councillor Beatty.
Thank you, Chair, and through you. I'm not sure if it's a referral or a deferral, so I'll look to clerks for the proper language. I had emailed Councillor Nan on Friday and unfortunately didn't have the opportunity to hear back, but it happened later rather than sooner, so my apologies to the mover. To have this referred or deferred, depending on the proper language, I'm still rusty, to our duly appointed and constituted school board liaison committees for review and conversation, so that we might try to look at this from a more collaborative, partnership-based framework lens, if you will, and sit down with our partners and say, how can we assist you? Because I don't think anybody's going to debate the fact that there are schools within the city of Hamilton and across the province that have less than robust HVAC systems, we'll call it that. Myself, having served on the school board previously in the role of vice chair, I had the great opportunity to visit a vast number of schools across the city, and all in varying degrees of dates of construction, shall we say. So the need is real, absolutely, but perhaps through this a referral deferral, we may be able to better understand how we may be assistive and collaborative on this topic, and working with our partners, both with public health and the duly appointed school board officials. So again, I've rambled a little bit, Chair, with your indulgence. Thank you. What is the proper language that I'd be looking for, Clerk?
So it would be a deferral, and it's only in order after all first-time speakers. And only if you
So
haven't
at the
spoken to
appropriate time, then, Chair, I would offer that.
So just to confirm, the deferral would be after all first-time speakers and would only be in order to be brought forward by a member who has not spoken on the matter.
And Councillor Beatty has just spoken to on the matter. That's my ruling.
Point of order quickly, sorry. You're saying it's a deferral, which would be, of course, it's a referral, actually, is it not? Because we're referring it to another body, not deferring it here. Thank you.
Sorry, yes, Councillor Kretsch, you are correct. But that would only be in order after all first-time speakers.
Okay, thank you for that. Clear. Councillor Beatty, yep.
So sorry, Councillor. It's the same thing
Yeah.
as I had mentioned, so it wouldn't be able to be brought by a member who has already spoke to the matter.
With an R for, okay, thank you. Like a reefer. Thank you. Yes, Councillor Clark.
So how would this work with my friend from Ward 10? He did speak to the referral and deferral up front and then spoke to it and then said, how do I bring it forward? So he kind of spoke to the matter and now he can't bring forward the referral?
No, sorry, go ahead.
That's what I heard, sorry.
Elsie Gauthier?
So I think that's fine, but that's the chair's ruling if that was spoken to, I would say. Like if you would consider that speaking to the item.
Another one for the governance committee, Chair.
I think clearly Councillor Beattie, in my opinion, spoke to his intent and why and offered reasoning. So he's spoken to it. Thank you. Next on the speakers list, I think I have Councillor McMeekin. Is that correct?
Yes, and I won't speak to it if it precludes me from either moving or seconding the motion.
Okay, thank you. I'm going to recognize Councillor Nan, second time, although I know she did introduce it, but are there any?
Thank you. If I could.
Point of order, sorry, Councillor Nan. If I understand what's happening here, Councillor McMeekin, if you said this correctly, you're trying to refer it. So he's the last first-time speaker. So he would refer it now, not before Councillor Nan speaks. Sorry.
Yep, and I was asking if there are any other first-time speakers to the motion. Seeing none.
Thank you, Chair. So I speak? Just to be clear.
I believe you would be a second-time speaker, and the instruction that Elsie Gauthier gave us is the referral occurs or kicks in after the first-time speakers have been exhausted. They have now been exhausted. So I have to go back to the referral. Do you have a seconder for the referral? Well, you said you were. Oh, but you cannot. Councillor McMeekin will. So just so that folks who are following along, the referral has been moved by Councillor McMeekin and seconded by Councillor Beattie. The referral is can you help me in the capacity as chair? Can we speak to the referral?
You can speak to the instructions on the referral.
And the instruction is to refer it to the liaison committee. Is that correct? Is that correct? Yes. Catholic and public. Correct? Councillor McMeekin?
Yes, and I'd be prepared to speak to it briefly, to the instructions, which is to refer it, and why that's appropriate, because I think protocol.
I'm just going to interrupt you, and I apologize for doing so, but I always think it's wise to look to the circle.
The instruction is not to refer it, it's what follows, so to the two liaison committees that were mentioned.
Sorry, Councillor Elsie Gauthier. What is debatable and what is not, please?
It's the instruction to send it to those two committees.
Is debatable.
Yes, just not the referral itself.
Okay, thank you.
Correct.
Well,
Mr. McMeekin, I apologize for interrupting you.
I'm a plain and simple man. It just makes sense that if we're going to articulate that we have a shared concern, a shared purpose to protect the safety of our kids, and we have a committee in place to discuss these salient matters, that protocol would seem to suggest to me, as a plain and simple man, that this would be an appropriate place to send it for discussion.
Thank you. Next, Councillor Danko, followed by Councillor Nan, and then I'll add myself.
Thank you, Chair.
Danko, are you speaking to this? Oh, you've declared a non-disqualifying. Yes, please proceed.
Yeah, so just so I'm clear, I didn't hear exactly that it's being referred to both school board liaison committees. And we also have two other school boards plus private schools as well. There's the French public and the French Catholic and private schools. So there'll be correspondence. So the liaison committees is one thing, but also correspondence with all other school boards.
I will look to the mover of the motion of the referral, beg your pardon.
I think that's a friendly amendment. I don't have a problem with that.
So it will, to the French boards, it will be in the form of a written correspondence along with the private. Is that what you're agreeing to? Thank you. Councillor Danko?
Yes, that's correct. Thank you.
Anything further, Councillor Danko?
Nope.
Thank you. Councillor Nan?
Thank you, through you, Chair. Just, parsing out all of the bodies that we need to consult with inside this motion is exactly why this motion was created. With the guidance of Dr. Richardson, recognizing that public health is in a very good working relationship with all of the boards that represent schools across all of Hamilton. And, it was her guidance and wisdom for this to be an all-encompassing motion as it is written, to not parse it out to the liaison committee. And it was never to suggest that public health is trying to take on the work of any existing school board or private education facility. It is to fulfill the goal of public health to receive data that they need in order to help understand the issue that children are experiencing as it relates to heat warnings that are declared by this municipality, by Dr. Richardson, and the subsequent impact of children, or to children of schools that have inadequate HVAC systems. So I appreciate what my colleagues are saying. I'm not trying to, derail any positive discussions that happen at the liaison committee. It is an effective body, but it's not an all-encompassing body. That's why this original motion was written in the way that it is. And I just encourage my colleagues to, take that into consideration as you decide whether or not you're going to support the referral. I certainly will not be.
Thank you. Yeah, it's my ruling as chair is Councillor Nan, in so doing, was talking about the endpoint and the frame within which that will be looked at and the counsel that she was offered. And that's what is informing her opinion as the mover of the motion on the deferral. I'm on next. I'll ask Councillor Taddison to assume the chair for me, please.
Carry on. Thank you.
Thank you. Very simply, I will not be supporting the referral for the following reason. This is a health matter. It is to be informed by health equity, and that information itself should inform all the consequences, the order, and the steps that come thereafter. It's a health matter. Thank you.
Back to you.
Thank you. Councillor McMeekin, please, on the referral.
Yes, it is a health matter. We all understand that. In fact, the mover of the motion, and I'm just thinking maybe I was too quick to suggest it was a friendly amendment, although I think it still is, actually mentions working with local school boards. That doesn't exclude the French school board or any other bona fide school board. Councillor Danko did mention private schools. I doubt that the mover of the motion specifically referenced that, but there was a reference to school boards here generally. And I think it's important as a courtesy to, and that's recognized in the therefore be it resolved. So I don't think there's Yeah, I think there's just a gentle disagreement around process, not around substance. The mover of the motion actually articulates that in her very motion.
Thank you. Any further speakers on the deferral and the path where it's going? Councillor Clark.
Thank you. On the instructions, can I ask, does the city of Hamilton currently indicate to the school boards when it's too hot for the schools to operate?
Dr. Liu?
To the councillor through the chair, no, that is not part of our direction.
Thank you.
And a second question, public health also doesn't do, we declare health emergency, heat emergency, cold emergencies, but that doesn't necessarily entail directions to the school boards in terms of what each school should be dealing with?
That is correct.
In form of instructions, would this instruction deliberation consider maximum heat temperature and minimum cold temperature in schools so that there is a set standard across the city in terms of when kids would be released from school because it's too hot?
To the councillor through the chair, my understanding is that would be the role and responsibility of the school board.
Thank you.
Thank you. We have a referral motion that's been duly moved and seconded. Oh, interrupt that. Recognizing Councillor Beattie for a second time.
Just trying to circle back to the instructions.
Yep.
The instructions as part of the referral to refer this to the duly appointed liaison committees with local school boards. I know for a fact that there are 2 duly appointed committees for each of the English-speaking school boards. I am not familiar with our liaison capabilities with our French language school boards. The amendment from Councillor Danko, I understand, would address that. This is a health issue, yes, but this is the process in which that this should take place, in my opinion, which is why I am seconding the referral motion, so that we can engage in conversation with our partners within their mandate to better understand and assist them with their mandate. That's the gist of my support for this instruction referral.
Thank you. There are no further speakers on the referral motion. It has been duly moved and seconded. We'll have a vote on that, please. Thumbs up from Councillor Francis. Seems to have an angry face with his computer. The referral carries 9-4. Thank you. Okay. I believe we have a notice of motion, and I will recognize Councillor Danko.
Thank you, Chair. I will leave this as a notice of motion because I think it would be beneficial to have some further conversation with staff and my colleagues. But the notice of motion is regarding the health boxes as part of the discussion today. And I'll just read the notice into the record. A, that the City of Hamilton write to the Minister of Health to request that the ministry does not fund the unsupervised distribution of drug paraphernalia, including needles and crack pipes, as part of health boxes. B, the City of Hamilton does not support the unsupervised distribution of drug paraphernalia without the oversight of a qualified healthcare professional with a focus on addiction treatment. C, that the unsupervised distribution of drug paraphernalia not be permitted on any City of Hamilton facilities. And D, that the City of Hamilton taxpayer funding to any community organizations engaged in the unsupervised distribution of drug paraphernalia be referred to the 2025 budget for consideration. And as I said, I'll leave that as a notice for the next Public Health Committee or possibly working with Clerk's GIC. Thank you.
Thank you. Any further notices? Seeing none. Before we move on to an adjournment, I know I speak on behalf of our committee, my committee colleagues, by recognizing the outstanding contribution that Director Jen Vickers-Manson has made as Director of Healthy Families. We thank her for her service to our city and to this public entity, and we wish her only good things. And with that, we have an adjournment. It's moved by Councillor Jackson, seconded by Councillor Beattie. I'd like to thank all the staff who assisted us this morning. Some very weighty topics, some very timely topics, and really appreciate the professionalism with which you brought your counsel, and to clerks as well. Thank you.